Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. It's a pleasure to start this session today. I have with me Professor Ayman Farghali from Medical Military in Egypt, Cairo. My name is Khalid al-Najashi. Just there is a slight change in the schedule that Dr. Sharifa could not make it for the program today. So there will be only 3 lectures.
Bismillah ar-Rahman ar-Rahim. Actually, it's my pleasure to be here, and I would like to thank Professor Abdullah and all the organizers for the fascinating meeting as usual, and the very nice program and the entertainment. Everything actually is so pleasant. It's my pleasure to co-chair this session with my brother, Dr. Khalid al-Najashi. The theme of this session is multidisciplinary, so I do believe that we're going to have interaction, and which is going to be the utmost that we can come out from such meeting. So it's my pleasure to introduce the first speaker, Professor Raghda Arif.
Inshallah, one day.
Professor Raghda Hussein Arif. Yeah? Professor Raghda is consultant pulmonology and pulmonary hypertension consultant in King Abdulaziz University, Saudi Arabia. Professor Raghda is going to deliver a talk, Timely Diagnosis in High-Risk Groups, with highlight on screening for PH patients.
Assalamu alaikum. Thank you so much, Prof. Ayman, for this nice presentation. Inshallah, one day I will be professor. I'm still an associated consultant. So good morning, everyone. It's my great pleasure to be here again in SAPH. I think I was talking to my colleagues. I think this is maybe my 3rd time. I believe so. We were wondering where was SAPH 2021? But virtual. We were wondering whether it was in Riyadh. So it wasn't in Riyadh. 2021, it was virtual? Okay. So my job today is to talk about screening. So to start with, we'll talk about the reason to screen for pulmonary arterial hypertension. So we have made significant advances on treatments for pulmonary hypertension to prevent clinical worsening, and we have an effective intervention now for SAPH, and we doubled the survival. And we know this from registries and from following our patients. However, we're still not doing that good when it comes to the time from symptoms to diagnosis. It remains unchanged. Patient will struggle for at least 2 years before he gets the diagnosis. And the reason for that is because of the initial PH symptoms are actually non-specific, and the patient will be investigated by primary health care for other reasons for his symptoms, more common like respiratory illnesses and cardiac illnesses, like left side heart disease, asthma, COPD. So why screening is important? This actually has been seen for a very long time. So since 2011, a study was done where they looked at the screening for pulmonary arterial hypertension in patients with systemic sclerosis. And based on the 2 cohorts, so they basically extracted data from registries. And if you can see here, this is the routine practice where basically they do echo to screen patient. They do echo for pulmonary arterial hypertension assessment in scleroderma patient when they got symptoms. And this one actually they do more of the screening echo to detect pulmonary arterial hypertension. And what they found that the patient underwent routine practice and they were not screened. They have more severe pulmonary arterial hypertension, they have worsening cardiac output, cardiac index, and they have worsening PVR. So that tells you that the screening actually allow you to detect patients in earlier stages of disease where you can actually treat them better and use medications and improve actually outcomes. And that also was seen, and you can see that the people were screened, the survival were better. Not only in 1 year, was also up to 8 years follow-up. However, the people were not screened and they were found to have pulmonary arterial hypertension because they were symptomatic, it was late, hemodynamic is worse, and they have worsening outcome. So when you want to put a screening strategies, you have a couple questions to come for you. So number one, who is the patient to be screened? What is the risk? What's the population at risk of developing PAH? And then you want to know, does the patient need to be, or the population to be screened need to be completely asymptomatic, or they can have early symptoms? And what is the risk of the screening? And what is the sensitivity and specificity of that test? And is it cost effective to do the screening? So what is screening? So screening in dictionary is basically systematic use of a single test or group of tests, and this is in risk individuals to identify the disease before actually the onset of the symptoms. However, this in practice has been extended that we can actually look for patients with mild symptoms, and the reason for that to look for early disease and early detection of disease. And this is basically what I show here in this diagram. If you look at the screening, asymptomatic patient, in PAH we have systemic sclerosis, liver transplant, BMPR2 gene mutation, and first degree relative of patient with hereditary or familial PAH. However, early detection of symptoms of patient at risk of PAH like connective tissue disease other than scleroderma, congenital heart disease, portal hypertension, and HIV. So in order to do this, you need to improve the detection of the pulmonary hypertension using based population approaches. So a screening test have to be sensitive, specific, reproducible, and is uninvasive, inexpensive, easy to be done and performed, and the result can be acted upon with further confirmatory tests. And the screening is not feasible in all asymptomatic risk patients. So it's essential to find a targeted population in this high-risk group where you're going to screen. For example, patients have low percentage of asymptomatic patients with portal hypertension to develop PAH, so it's only 2 to 6% prevalence, and HIV it's only 0.5% to develop PAH. So it's not reasonable to do wide programs and wide-scale screening programs because it's not going to be cost effective. So this is why we care about screening. Patient journey to get a diagnosis is too long. From the time he developed the symptoms, the initial breathlessness, until he gets a diagnosis by right heart cath in a confirmed specialized centers, it can be years. Surveys from patients has shown that also in developed countries, not only in the developing country, that actually it takes up to 2 to 3 years to get the diagnosis from the onset of the symptoms. You can see the patient can go through seeing multiple physicians, primary healthcare physician, family doctors, specialists, undergo multiple testing to be done. He can receive trial of treatment for other condition, assuming that he has asthma or COPD, and further trial of treatment until the patient presents actually late with symptoms of syncope, palpitation, decompensated heart failure. At that time, he will be investigated for possible pulmonary hypertension, or they'll do an echo or CT, they'll find PE, CTEPH, or PH. So how would you improve this? We need to improve the detection of the disease and reduce the time to the diagnosis. So we need to improve patient awareness, because this is basically utilizing a large healthcare data, insurance, clinics, hospital episodes, emergency visits. So what do you need to do? We need to improve our application of the diagnostic measures and find better strategies to screen the disease. So this recommendation for high-risk group has been made by multiple guidelines: American Cardiology Society, American Heart Association, ECS and ARS, the Australian groups. They made recommendation about screening for asymptomatic patients in patients with high-risk group. So what does the guidelines 2022 tells you? So if you have a patient, you can notice that now they actually put a new diagnostic algorithm. And the reason is they want you to detect patients with PH in the community. So this algorithm is more targeted toward family physicians and GPs. And you want to expedite referral to these people who are high risk or having complex PH. So you want to identify other groups, left side and pulmonary disease, and also you want to identify PH patients with actually comorbidities, and the screening strategies were actually proposed. So this is the diagnostic algorithm. As you can see, it's targeted toward family physicians and GPs and primary healthcare physicians where they have somebody with unexplained dyspnea and the suspected PH. So the algorithm is started by doing basic investigation, and then you can go into suspected cases for left and right heart disease, and then you assign probability for pulmonary hypertension. I do? Okay, thank you. So what are the warning signs that you will basically send your patient immediately to be seen in PH centers? These are the warning signs. So of course, signs of decompensation on right side heart disease. What are the risk factors? These are the risk factors also mentioned in the guidelines. These people, you need to send them immediately, and this is for GPs, primary health care, to be investigated in a center where they have expertise in pulmonary hypertension, because these people have risk of PAH and they have risk of CTEPH. So screening the high-risk group is basically screening asymptomatic patients. For example, in scleroderma, where the prevalence is actually up to 20%, patient with BMPR2 mutation, where the prevalence can be up to 40%, and patient with first-degree relative of HPAH. And the reason for that, this is the high-risk group. Prevalence will be the diagnosis significantly impact the proposed intervention. Also, portal hypertension patient, but not at any time. At the time they're going for liver transplant. Early detection and symptoms will be in patient with high-risk group, like portal hypertension at any time, connective tissue disease, but not scleroderma. And the reason for that, because these people, if you do the prevalence of the disease doesn't support to do asymptomatic screening for all the group. So only you basically screen people for early detection of symptoms when they have early symptoms. They are not completely asymptomatic. So high-risk group, systemic sclerosis, BMPR2 mutation, portal hypertension, and pulmonary embolism. Most important, scleroderma. Why? Prevalence is up. Diagnosis, accuracy of the echo to detect PH in this group is actually suboptimal. You have to have combined strategy using not only the echo, also biochemicals and BFT. And it's suggested to do a multimodal approach here to prevent sending a lot of patients for right heart cath unnecessarily. And also you can diagnose patients with borderline, what we call new definition of mean pulmonary artery pressure. Before, we don't treat them yet, but we know that they're going to develop the ranges of pulmonary arterial hypertension, where we start treatment at mean pressure more than 25. So what are the phenotype of these patients? They're usually short of breath. They have longer duration of disease. They are male patient, older in age. They have digital ulceration. They have positive ENA, mild ILD, low DLCO, elevated ProBNP. And the recent meta-analysis did show actually that reduced digital capillary density is actually associated with risk of pulmonary arterial hypertension. So this is how do you basically look for risk factor for PH in patients with scleroderma. So what the guidelines tell you, patient with scleroderma, annual evaluation for risk of PH is recommended, especially if they have the disease more than 3 years, their DLCO is less than 60, and their vital capacity is more than 40. Please screen these people for risk of PH, even if they are asymptomatic. And in patients where the breathlessness is still there, you cannot identify why they're short of breath. Through doing non-invasive measures, including doing some exercise study, you might actually consider doing right heart cath. So this is the DETECT algorithm. I think everybody is familiar with this. It's two-step, and basically it's very sensitive, non-invasive, and it's going to tell you what to do, whether you send your patient for the echo or you send the patient to the right heart cath. So what's the DETECT algorithm tells you? It identifies PH patients with less severe hemodynamic, so early disease presentation, significantly reduce the misdiagnosis of PH, and also reduce healthcare resources and identify patients with early pulmonary arterial hypertension. So identify patients in earlier stages of the disease where the treatment can be more amenable and you have better outcome, as the study illustrated. This is other way of doing scleroderma by the Australian group and by itinerary scleroderma algorithm as well. All of these are effective algorithms to detect early disease. So if you have patients that have, having risk of PH and the evaluation for symptoms, combination is basically multimodality. So it's not just doing an echo. It's echo, BFT, ProBNP, and combining all of this to know whether your patient have PH or no, and policies in hospitals should be actually established to evaluate the risk of PAH. Okay, BMPR2 gene mutation. So the mutation carries a lifetime risk of 20% with different penetrance over male and female. Currently, there is no accepted screening strategy to evaluate PAH in patients with BMPR2 gene mutation carrier, and we don't know when to screen them, for how long we screen them. The asymptomatic relatives who screens positive for PH causing mutation are often offered to have a yearly echo based on expert consensus and expert opinion. And a recent study that showed that the annual incidence actually is only 2.4. So I believe it should be also a multimodal approach. So it's not just doing an echo, doing assessment, and to look for risk of PH in this group of patients because they are high risk. In portal hypertension, they can develop PH and liver disease. The screening is advised to assign a probability based on echo, and in agreement with the International Liver Transplant Society, this is advisable to do when the patient basically being considered for transplant yearly, because we know they have mean pressure more than 50, they have higher mortality for transplant. So we need to put them in PH target therapy before we transplant them. So this is the recommendation: counseling regarding risk of PH, annual screening recommended, whoever tested positive for gene mutation and first degree relative of HPAH, and in patient referred to transplant, echo is recommended to be as screening method for PH. And an echo is recommended in all liver disease with signs and symptoms just of PH, if they have symptoms, and the screening tool, patient evaluated for liver transplant or TIPS. And it's recommended for patient with PH with portal hypertension referred to expert center. We'll talk a little bit about PE. I know there is going to be a session, but just a little bit. We know that reported cumulative incidence of CTEPH after an acute symptomatic PE is wide range, can reach 10%. Systematic reviews meta-analysis reported incidence of CTEPH to be 0.6% after an acute PE, and a recent observational study did show that the cumulative risk of 2-year incidence is basically 2.3 and 16 after an acute PE. So echo preferred to be, again, the first-line diagnostic measures to patients suspected to have CTEPH. Current guidelines do not actually recommend that you can do images for each patient after an acute PE to look for CTEPH. However, 50% of these patients are going to have some kind of diffusion defects, and we don't know whether all of this is clinically relevant. And current guidelines will tell you to basically consider patient at 3 to 6 months evaluation for CTEPH if they have risk factor for CTEPH. And this comes with the time we assess the patient about the duration of the anticoagulation. So this time, assess if the patient having any risk of CTEPH, and you can consider doing an echo at the time. So this is the guidelines. If you have any patient who have persistent symptoms, new onset of symptoms, exercise limitation after an acute PE, diagnostic evaluation should be considered. And if the patient having a mismatch defect beyond 3 months on anticoagulation, refer this patient to expert center. And again, it's a multimodal approach, echo, proBNP, and sometimes exercise testing to identify patient at risk of CTEPH or actually at risk of CTED right now. So quickly, congenital heart disease, 10%. They have estimated to have PAH, and the presence of PAH can actually present in the diagnosis, and some of them, they can develop PAH later on in life, and we need to keep an eye on this patient, especially the one undergo correction. Either after correction or longer time, they can develop PH. So my take-home messages is strategies for screening, improved detection of PAH, and required for both two groups, asymptomatic patient like scleroderma and early detection of patient whom PAH not considered to be an initial diagnosis. Until now, the best way to apply the existing and new strategies is still challenging in PAH, and the creation of the screening algorithm for risk of PAH, scleroderma related, has increased actually the speed and the specificity to diagnosis and potentially improved survivor. However, the screening cost is remaining significant, and most of our PH patients present with breathlessness with exertion. So a developmental of specialized clinic where they can be investigated in a timely manner is the best way to try to reduce time until diagnosis. Thank you.
Thank you, Professor Raghda. I think you can join us, please. We'll keep the questions as usual at the end of the session.
Assalamu alaikum. So it's a pleasure and honor to present the next speaker. He's Dr. Hussam Sakija, consultant pulmonary critical care and sleep medicine from King Fahd Medical City. He's an active member of SAPH. He's going to talk to us about severe RV failure.
Assalamu alaikum. Good morning, everyone. Thank you, Dr. Khalid, for the presentation. This is too tall for me. It's my pleasure to be with you here in our annual meeting. I was given the task to talk about ICU management of right ventricular failure. Probably you've heard me talking about this before. It seems that we have a little bit of gap in our practice, simply because the number of cases are not that large, and probably the majority of us are not practicing ICU as the traditional model for our practices. Patients with pulmonary hypertension that you have been talking about, that you have diagnosed, and you have started them on treatment, whether double or triple, eventually they will progress. We know that. And ultimately, they will require lung transplantation. In between the two journeys, the patient will eventually succumb to their disease. And this is the most dreadful, unfortunate reality when we deal with pulmonary hypertension. How do they die? The majority of them, they die from progressive right ventricular failure. And some of them, and I sometimes call these are lucky ones, that they will have sudden death in their best usual state, and suddenly they just have an arrhythmic event and they pass, unless they get the opportunity to get transplanted and they have a new life that's written for them. In between, we do care for these patients. The mortality overall is getting better. The overall care for the patients is improving. The actual number of patients that are existing in the society, the prevalence, is becoming higher. And these people are expected to require some services, including intensive care, whether due to progression of their disease or due to some other event that took place. We have viral pandemics. We have some surgical things that happen. So really, we have to be very aware and familiar with how do you deal with them when they go into the ICU, from whether the right ventricle is failing and that's the reason for their admission, or they have some comorbid illness that requires their ICU environment. Majority of the time, by the time the patient arrives at the ICU, they have a very unusual physiology that's not supportive of the pulmonary vasculature. Whether they are having pneumonia, pulmonary embolism, they have sepsis, they have an inflammatory syndrome, they are put in mechanical ventilation for whatever reason. This is not a good thing for the right ventricle. And sometimes we do things in the ICU that is reactionary, and most of the interventions we do is intense and rapid, with that sometimes knee-jerk, if you wish, at times, because we are here putting the goal of saving the patient life as a priority. So probably we don't pay attention to the fine details. You need to give fluids, the patient's hypotensive, you put them on inotropes, you have to give sedation, and sometimes, all these measures is not very, very healthy. We know that our disease, pulmonary hypertension, will progress over years, and the pulmonary circulation itself is not very healthy by virtue of the disease itself. The PVR is progressively getting higher. The pulmonary circulation is unable to accommodate what we are dealing with, and consequently, the right ventricle is having to deal with this pathobiological concept that, it has to just really try to overcome the demand that is put on it. Now, in the chronic state, this right ventricle will try to accommodate. We have inherent genetically modified properties that will make the ventricle try to accommodate. And there's two types of accommodation, whether it will be adaptive or maladaptive. If it's adaptive, the ventricle will really build good muscles and it will maintain its function. These cases are great. We see them. You see a patient with very severe pulmonary hypertension by numbers, but they are doing fine clinically, to a point where sometimes they will progress to the to the maladaptive phase. There will have a lot of fibrosis, the ventricle will dilate, it will start accumulating more volume, and this is, of course, not that good. Some unfortunate patients, the process of adaptation is faulty to begin with, meaning that they are from the beginning unable to really deal with the elevation and the pressure down the stream, and they start having earlier symptoms, and they do have sometimes worse outcome. This is just a picture of how does the adaptive and maladaptive right ventricle look like, depending on the case that we are dealing with. Now, these are pictures of adaptive and maladaptive ventricles in a real-life patients that we have in the clinic. On the left-hand side, the patient is congenital heart disease. The ventricle is pumping very nicely. It's able to accommodate the elevation and the pressures down the stream. Patient is functional. She goes to her work every day. On the other side, the right ventricle is more dilated. Obviously, there is more volume in it. And of course, the patient's symptoms are much worse than the others. Normally, the right ventricle is a very easy, like conduit, like chamber that will conduct the blood from the systemic into the pulmonary circulation. Under normal rest circumstances, the right ventricle is unneeded, really. It can really pass the fluid from the left side to the right side because there is a big difference in the resistance across the two circulations. And the pumping of the blood will be required if you increase your need for cardiac output, if you exercise. And remember, the left ventricle is not a separate chamber. They are living next to each other. The contraction of the healthy septum in normal circumstances actually contributes to the right ventricular cardiac output, and this is very important to keep in mind when we deal with these patients. This is physiologically reflected by this somewhat complicated like pressure volume loops in the right side, and there is a big difference between the right and the left. On the left side is the normal right ventricle where there is no isovolumic contraction. So just what I told you now, the flow is almost continuous. There is no phase where the ventricle will contract and the pressure will increase without having movement of the blood across the circulation. It's almost continuous. As the disease progresses, as the pulmonary hypertension becomes more significant, it will take the picture of the left ventricle, meaning that the muscle is higher. Sometimes you start building a pressure so that you will really have to overcome the resistance down the line, and this is what is seen in pulmonary hypertension. So the two systems are connected, whether we like it or not. There is a demand from the pulmonary circulation in the case of pulmonary hypertension, and there is a supply that is the right ventricle. We cannot separate the two together. This is a very interdynamic concept that we have to understand when we deal with these patients. Now, the right ventricle physiology is completely different than the left ventricular physiology because of multiple reasons. The right ventricle is unable to generate enough pressure to deal with sudden increase in the PVR, and this is obvious. The left ventricle, you can handle whatever blood pressure that comes across you. But the right ventricle is weaker, the structure of the muscle is different, the geometry of the right ventricle is different, and you cannot really generate high pressures. If you see somebody with acute right ventricular failure and they have high pulmonary artery pressure, there is a chronic process that has been going on probably for some time and just happened that they decompensated. The consequences of this acute increase in the PVR will be reflected in the cardiac output. In the left ventricle, the cardiac output will probably be maintained. But in the right ventricle, there will be a precipitous decrease in the right ventricular output. And that's when the patient will become shocky. That's why florid right ventricular failure, the patient is usually in shock. And we see this, unfortunately, commonly in the emergency room, whether the patient is known or unknown, and sometimes in the ICU when they get into some comorbidity and they will just start going down the drain. So this concept that I was talking about is the afterload, and the afterload is the stress that the ventricle has to generate in order to overcome the resistance and maintain the circulation. The right ventricular function depends on other factors, one of which is very important to understand is the preload. We always say pulmonary hypertension is a preload dependent. Yes, the patient is overloaded, but this preload, if it becomes critical, the patient will unable to maintain the cardiac output. So you have to maintain higher preload than the normal so that the ventricle will continue at least to function. And this is partly, it will take place in the good adaptive ventricular hypertrophy. Of course, inotropic consequences might contribute some, but remember, the normal right ventricle is very thin, and the amount of the muscle in it is much less than the left ventricle, so sometimes the inotropic effect might not be as strong. So volume is very important, and physiologically speaking, the slope of the right ventricle, volume versus cardiac output or pressure, it is more steep than the left ventricle, meaning smaller changes in the preload have more significant outcome in the right ventricular side than the left ventricular side. So if the patient is a little bit dry, if they are preload, that means that their consequences might be higher and they might not be able to maintain cardiac output. We see this all the time because in the ICU, we have plenty of cases that will cause the preload to go down, even the patient is overloaded, but they are unable to maintain enough volume to push the blood forward. Now, the adequate filling pressures usually should be a little bit higher in the pulmonary hypertension, and keep this in mind. We would like to have a little bit higher filling pressures in the ventricle, not too high, because too high that will fail the ventricle according to the Stirling law, but you try to maintain it where it is maximized, where it will maintain its function. When the right ventricle is dealing with failure occurs with patients who's normal, the circulation in the pulmonary side is normal, like what happens in right ventricular infarct, or sometimes there will be a post-operative changes that made the right ventricle to be stunned. The treatment is a fluid. If you don't fill the tank enough, the patient will die. This is not the case when the circulation is at fault, because this fluid will eventually affect the right ventricle itself, and it will fail to pump. So this is the balance. That's probably partly the complexity of the two cases when we deal with the patients. And these are the basis of how do we manage right ventricular failure in the ICU. Again, physiologically speaking, the A curve is the normal. The B curve is a patient with pulmonary hypertension who's able to handle it. There will be ability to increase the volume to some extent that will maintain higher pressures inside the ventricle to push the blood against the higher PVR. And when they decompensate, meaning that they present with a florid right ventricular failure, the volume status will be even more pushed to the right side, meaning that they have more end-diastolic volume, and consequently they will be unable to generate enough pressure to push the blood where it can be oxygenated. We said the ICU, there is a lot of factors that can even momentarily change this preload. A little bit of a bleeding, a little bit of sepsis, maybe sometimes even medications we give. Every time you give a sedative, the blood pressure will drop. You have to be aware of this. This drop of the blood pressure might start a very serious and deadly pathway that the patient will probably not be able to come out of it. And the other concept that we talked about it is the interventricular dependence, and this is very important. This patient is currently in the hospital, out of the ICU. This is his first presentation to us. It looks like he did have severe pulmonary hypertension before, and he came in with shock. This is the first time we see him, Shaya and I. He was in shock. He was on 3 inotropes. His liver enzymes were very high. His kidney function is abnormal. His lactate was above 10. And he was starting to have mentation issues. We managed to get him quickly. We identified, like the story goes, most likely he did have pulmonary embolism before. This is a CTEPH case, and now he's having a small, very small PE on top of all of this. We thrombolized him. Within 2 hours, the patient has significantly improved. He's off inotropes, lactate almost normalized within 6 hours, and kidney function start picking up again. This is the interventricular dependence that we talk about. He was in failure. His left ventricle was unable to accommodate any venous return, and the patient really was in a very bad shape. He still is in a bad shape. We managed to get him out of his acute decompensated state, but when we cath him, his pressures were very high, and his right atrial pressure was like 22, which is reflective of very severe high right ventricular filling pressures. With all of this, for the ventricle to be able to maintain this pressure, it has to pump, and muscular pumping will affect the vascular supply of the right ventricle. This is another difference between the right and left, where the right ventricle gets blood supply continuously, very low pressures. During systole, even diastolic systemic pressure is higher than the pulmonary side, and it will have continuous flow. When the ventricle start pumping and start building some muscles, the systole will be gone. The influence of the systolic supply of the ventricle will be lost depending on the level of the pressure elevation. And that means they will be very much dependent on the diastolic blood supply, similar to the left ventricle, and relatively they will be ischemic. And you will see sometimes patients coming in with somewhat okay ECG changes of right, pulmonary hypertension, and then will go into very deep subendocardial ischemia, and sometimes they progress to elevation in their troponins, and they do have myocardial infarction. The supply demand, if you are healthy, you can handle it. The ventricle has some capacity. there is an increase in the supply, the ventricle will try to accommodate. But when the pulmonary artery circulation is abnormal, when there is a significant pulmonary hypertension disease, that is not necessarily the case. And the demand will be higher than the ability of the ventricle to handle it, and the patient will have what we call pulmonary hypertensive crisis. Now, I made it so general because this crisis can be precipitated by anything. Whether it's like a progression, slow progression, and suddenly something will happen. A little bit of hypoxia sometimes will put the patient off this balance. A little bit of volume changes across whether preload or afterload will put this patient under very, very critical condition, and the right ventricle will fail. Understanding these physiologic basic concepts will help us how to manage them later on. So increase in the PVR by any means, and all of these things can increase the PVR in the ICU. Whether it is infection, it's related, a little bit of arrhythmias. Even the arrhythmias, the ventricle will have a very preload insufficiency. When the atrial fibrillation takes place, the ventricle is not getting enough blood, and that can put them into really this bad circle. Eventually, the right ventricle contractility will be affected from ischemia, from the lack of the ability to generate pressure. The right ventricular and diastolic pressure will go up. This will be leading to more ischemia into the right ventricle. The left ventricle will be affected because of the decrease in the cardiac output to the left side and the interdependence. Usually the ventricle will be affected, as I showed you in the echo, that the left ventricle is really pushed, marginalized to the point where it's not able to accommodate the venous return, and eventually systemic hypotension will start. And this is probably the start of badness. And when they get into that phase, really it becomes very difficult. This is just showing you the impact of acidosis, whether it's respiratory or metabolic, on the PVR. It can have multiple numbers increase in the PVR, and this happens sometimes acutely. Ischemia the same, whether the patient is having PE or having hypoventilation from whatever event. Anesthesia can be very risky business. It's a normal, straightforward process. They have to pay attention to this because a little bit of ischemia can really lead to the problems that we have. I don't want to go through the critical care part, but sepsis is very common. These patients, a lot of times, they die from sepsis, and there's a lot of factors, inflammatory markers in sepsis, that simulate the even pathophysiologic mechanisms that lead to the pulmonary hypertension, and consequently, it's contributing to the increase in the PVR. This is a little bit complicated slide, but there's two mechanisms to calculate the interventricular dependence, or if you wish, the coupling between the ventricle and the pulmonary circulation. Don't worry about it. It's a little bit of advanced physiological concepts, not available in all the even cardiac cath labs, but eventually you are looking into the two interactions between the two. The ES, the end systolic elastance, this reflects the right ventricular function, the ability of the right ventricle to pump, and the line between the end diastolic, do we have laser? The line between the end diastolic volume and end systolic volume, this is basically the cardiac output of the right ventricle, and this reflects the ability of the pulmonary circulation to accommodate the cardiac output. The balance between the two is what we are looking at, and there is an equation that you get into the slope, this slope over this slope, and the numbers normally is more than 1.5. The more advanced the situation, the more complex the disease, the balance will be getting off. And this balance between the elastance between the ventricle and the artery will be out of balance. It will be decreased, basically. Anything below 1 is really bad, and anything below 0.6, probably the patient most likely survival will be nothing. Now, this concept has been studied in a lot of animal models, and look, whether simulated or an actual cath lab, and they start looking into different factors that can influence the right ventricular function, and all of them, there will be tipping off the ventricle, and the vascular coupling will be affected. All of the times, it will be decreased. So when we have a decreased right ventricular output, this will lead to dilatation because the ventricle will be unable to accommodate the volume. It's easy. There will be more right ventricular end diastolic volume. This will decrease the left ventricular filling pressures and output, and this will decrease the supply. This will lead to right ventricular ischemia, and the whole body system will be affected with a systemic hypotension, and a lot of times there will be backup pressure into the vital organs. The gut is one of the serious ones because transmigration of organisms will take place, and eventually they will have an infection whether we like it or not. And once they get into this phase of downward spirally, the outcome is usually bad. Unfortunate, it's fast, quick, we've seen it. Sometimes within a couple of hours, anything that does not address this balance will lead to really significantly poor outcome. So the patient is with us in the ER, in the ICU, in the recovery room. How do we monitor them? We monitor them similar to any other patient in the ICU. We try to get a CVP line for them, almost all of them, minimum. CVP is not something that we like to do anymore in the ICU. It just does not really reflect the volume status. But we use the CVP here as a surrogate of the right ventricular filling pressure. It gives you an indication what is the right atrial pressure is, and this is what we really need to see how bad they are. So we don't use it to give fluids. We use it to be more aggressive with diuresis, if you wish, because this is very, very important. We know what is going on. We know the patient needs to have less volume. Echocardiography is nice, and I think a lot of intensivists now are very familiar with the POCUS. Like at the bedside, they can have assessment. Hopefully, they will be able to be, just take a look into this right-left ventricular interactions. And sometimes, in selected cases, you might need to go for a PA catheter, where you will monitor things very aggressively. If you have the capacity, if you know the how, probably this will be a very good option. Or if the patient is very sick, sometimes you end up putting S1 GANs and you're really unable to interpret the data. The nurses are unable to calibrate, and there's a lot of noise that can influence your decisions unnecessarily. But ideally, sometimes you do resort to this. Any precipitating factor that you can realize that you have to correct it. You have to, if the patient is having hypoxia, you have to correct the hypoxia. Pneumonia, you give antibiotics. A little bit of hypotension from sepsis, you have to address sepsis as such. And in our ICU, try to avoid the negative inotropic medications, stop the vasodilators, stop the beta blockers, and this is very important, and this is just a knee-jerk reflex. It might not help the right ventricle at that point, but it will stop something that will add up to the problem that we have. Common issues that I will start with the lung, since we are dealing with pulmonology at large, is that we have to optimize the lung condition. Sometimes these patients might have a pleural effusion that can put them off balance. So if we can manage this pleural effusion, that will be great. Sometimes we have to give them non-invasive in order to improve the atelectatic state they are in, just as a recruitment tool to open up the alveoli. If they are not intubated, try not to intubate them. We have very good success now with the high-flow nasal cannula system, because if the patient is hypoxic, you really can rest them and give them very high flow to a point where you can prevent intubation, and it's worth trying it in these people. Probably I will go with high flow before I go to non-invasive, but again, this is another modality to prevent intubation. Intubation itself is really risky. The process of intubation, the immediate post-intubation phase can lead to problems. If they get intubated, we have to be very careful that we maintain good oxygenation, avoid hypercapnia, because patients will hypoventilate around the time of intubation. They become acidotic. Acidosis will increase the PVR, and it might precipitate or exaggerate the response that we talked about. And of course, in the ICU, people like to use PEEP. PEEP is good. It's our friend sometimes, but this is not good for pulmonary hypertension patients. Try to avoid using very high PEEPs. And again, another concept that we do in the ICU is decrease the minute ventilation or the tidal volume. This will lead to permissive hypercapnia, and again, it will get us into this circle. So everything we do, it has consequences, balance, and trying to understand what is it that we are doing probably will be the best thing that we do for the patient. Best pressure is to ventilate the patient in the functional residual capacity. Anything below, it will lead to atelectasis and increase in the PEVR. Anything above, it will start pushing into the pulmonary circulation, and it will increase the resistance. How can you find this? Tough. So again, you have to just maneuver it a little bit where you can maintain it. The process of positive pressure ventilation in general is not good, because this will influence the preload. And we said the preload is very sensitive. Sometimes the patient will really collapse. They are very edematous, but they are unable to maintain enough preload to maintain cardiac output. When we intubate them, we have to use the nicest medications. Ketamine is not bad. Sometimes rocuronium is healthy, does not affect the pulmonary vascular resistance. Anticipate hypotension during the process of intubation. Sometimes we give phenylephrine handy just to maintain the blood pressure, because if they become hypotensive, again, that might precipitate this very vicious circle. Pre-oxygenate them to try to avoid the lowest time of hypoxia possible. And when we intubate them, we immediately connect them to the ventilator. Keep bagging them. This will give them very uncontrolled PEEP effect, and that can be very risky as well. And of course, we will try to be cautious with protective lung ventilation, because it's not very, very good. And always pay attention to the hemodynamics of the patient. CVP, I talked about CVP. We try to maintain it a little bit higher. It's something falling out of the ICU practice in general because we have other better tools to assess volume responsiveness and volume status of the patient. But here, try to use it in order to control or to manage your cases. You have an edematous patient who requires a fluid and vice versa. How much to give? When do you give inotropes? So we use this. I'll give you an example to make it a little bit clearer. We wanted to maintain mean circulatory pressures because of all these good things. It will prevent ischemia, it will prevent organ dysfunction, and of course it will maintain blood supply to the heart, and our optimal target pressure will be probably above 65. Be liberal. We don't go with the limits because these patients have to overcome what we call the perfusion pressure. So we calculate the perfusion pressure by subtracting the CVP from the mean like arterial pressure. Just a quick example, if the pressure is 60 mean, we're good. In the ICU, we're happy. We like it to be 65 sometimes. But if the CVP is 25, the actual perfusion pressure is low. So you do give aggressive, inotropic or vasoconstrictive medications to improve on this. So we do recommend giving vasopressors. Almost finished. This will lead to increase in the MAP, and the difference will be better. The patient will start perfusing. They will start making urine. We are getting rid of some volume. Now, when we get the volume out, we might be able to decrease a little bit of Lasix, and this will probably eventually lead to decrease in the MAP down to 65, but the patient is getting better. So this is how we try and manage the inotropes versus fluid situations. Best medications to give, some of them are not good. Phenylephrine is bad. We always give norepinephrine and vasopressin. Levosimendan, it's a theory. We don't have it in Saudi Arabia, unfortunately, but it can be good for the left ventricle. And the studies on these medications came from the same concept that I mentioned, the pressure volume concepts and the coupling, where you do want to see improvement in the coupling and in the function. ICU is a unique place. We can do things that's not normally available in the medical wards. We do have NO, and we have IV therapies. We sometimes have to support the ventricle if this is not enough, and we end up doing ECMO, and hopefully, the patient will have a very clear plan before we put them on ECMO. The outcome can be good, but you have to have a plan. Is this an ECMO bridge to transplant, or just put them on ECMO is not a very good thing, and I think this was I will stop here, but be careful with the preoperative patients who will need to come to the ICU. These patients, they have to be very well planned. Planning in anticipation of a crisis is probably the best approach, and when it happens, we'll deal with it with the way we know. In the ICU, we always try to do good, but trust me, I think we lots of times cause harm down the way without being even sometimes paying attention to it. Thank you.
Thank you, Dr. Hussam. So we will be leaving the question till the end. And there is just an announcement from Mr. Hassan Al-Raini that it's not written in the schedule that the lunch today is the same and the same place after the second session, after the last session. It gives me now an honor to present Professor Damien Bonnet, a congenital cardiology and pulmonary hypertension professor on University of Paris. Welcome.
Thank you very much. I would first like to thank Professor Al-Dalan and Professor Al-Raini for inviting me and for this very nice meeting. I mean, for a doctor who is taking care of children, it's always very fruitful to have a strong interaction with the adult doctors, and I think that I already learned a lot. So I would try to show you in this 20 minutes the management of pediatrics pulmonary arterial hypertension, and try to show you how the current guidelines have been updated. Oh, this is not this, it's this. So these are my disclosure. The first, pulmonary hypertension in childhood is very similar to pulmonary hypertension in the adult population, but there are some differences that are important to know, and we will go through these. First, the epidemiology, and I will just say a word about that. The etiology, genetic background, of course, age-dependent diagnostic procedures, particularly the right heart cath, the treatment approaches, and the disease monitoring. For the epidemiology and classification of pulmonary hypertension, it's completely different from that in adults. We deal every day with children who have pulmonary arterial hypertension, but these are completely reversible, either because it's persistent pulmonary hypertension of the newborn or because it is associated with a post-tricuspid shunt that after closure will lead to a normal pulmonary artery pressure. So this is a very big population because it represents more than 80% of our population with pulmonary arterial hypertension. And the rest of the population is made of idiopathic pulmonary arterial hypertension, heritable, and some associated with congenital heart disease that cannot be cured or with coincidental shunt. The other aspect is that I will not go through a lot today, is that a third to a half of the population of children with pulmonary hypertension have respiratory disease. So it is a big group, and what we have learned recently is that there is an overlap between this group of respiratory disease and PH and the group of pulmonary arterial hypertension, particularly through the identification of mutation in genes involved in the cardiac and in the lung development. So there are roughly two big situations in pediatrics. The first one is the neonatology, that is a complex situation in which you have all these developmental disease, prematurity, congenital heart disease with complex anatomy, and a lot of difficulties to confirm the diagnosis because for the majority of patients, you cannot confirm the diagnosis with right heart cath, particularly in babies in the neonatal ICU. So I will concentrate on the child because the child is closer to the adult and show you what is in the current guidelines about the management of children with pulmonary hypertension. The second difference is the genetic background. There is a high prevalence of genetic anomalies in children with pulmonary arterial hypertension, particularly chromosomal anomalies, a variety of syndromes, and mutation in the same genes than in adults. It's very important to know that because today, for example, in the Down syndrome, it has been shown that the pulmonary development and the anomalies of the pulmonary development are responsible for the early onset for pulmonary arterial hypertension in children with Down syndrome and congenital heart disease. There are, as I just mentioned, new genes involved in pediatric PH, TBX4 and SOX17. We discussed of that recently, and they both contribute to pulmonary arterial hypertension and congenital heart disease. So as an example, a child with an ASD, 4 years old, and severe pulmonary arterial hypertension, you should have adopted that the pulmonary arterial hypertension is related to the shunt. So today the advice is to test them for this mutation, and we found a lot of them. There are also some peculiar Mendelian inheritance because with the genetic screening that we perform for all patients, we found children who are homozygote for PAH gene or compound heterozygote. So it means that the prevalence and the penetrance of the pulmonary arterial hypertension in children might be related to the number of genes that are mutated as we see in hypertrophic cardiomyopathy. And finally, and I will not go through that, the genetic counseling and familial screening is also an ethical issue. Should we detect pulmonary hypertension early in children of parents who have pulmonary arterial hypertension? That's what we do, but ethically, it may pose some problems. So the diagnosis is the same. The definition is the same, but we index the pulmonary vascular resistance to the body surface area. And the diagnostic workup should be complete and should include a right heart cath. This is absolutely mandatory and should also include a vasoreactivity testing that should be interpreted according to Silbon criteria, so exactly the same than in adult. The second aspect of the right heart cath is that today we don't have any information that vasoreactivity testing defines reversibility or operability in children with congenital heart disease, and we don't do that anymore. Of course, the main problem is to do the right heart cath in small babies, and that's why this definition applies to children more than 3 months of age, and with 2 ventricle anatomy. Of course, in single ventricle anatomy, it may be more difficult. So today we don't have a clear definition of what is pulmonary hypertension in children less than 3 months of age. It is absolutely mandatory to do the vasoreactivity testing, and we have seen in registry that it is not done correctly in a high proportion of patients, because as in adults, high-dose calcium channel blocker is very efficient, and the mortality is almost null in these patients compared to the non-responders. So it is a clear issue as it is in adults. There are also some other hemodynamic predictors at baseline that you can retrieve from the right heart cath at diagnosis. You have here a series that we have done recently that shows that PVRI, right atrial pressure, compliance, and stroke volume index are associated with outcome with different thresholds from that observed in adults. This risk assessment that includes hemodynamic variable is very important to guide the treatment and the risk of progression of disease and risk of mortality, and when to escalate therapy during follow-up. And I will show you that just after. There are some factors that you cannot change. I call them non-modifiable factors, and as in adults, you can see here that the majority of patients with PAH still have a poor outcome. After 6 years, the survival is about 70%, and PVOD has a very poor outcome if you're not transplanted. There are also some risk assessment factors that are not modifiable, and they rely to genetic anomalies. For example, the FOXF1 mutation in neonates who have alveolar capillary dysplasia and a fatal outcome. And also very small variations, for example, in SOX17 that are associated with survival in pediatric and adult pulmonary arterial hypertension. So you can stratify with these non-modifiable factors, but it is, of course, not of practical importance for the patients. The other factors are exactly the same than in adults. It's functional class, the symptoms of right heart failure, progression of symptom, NT-proBNP, right ventricular function, and hemodynamics. So the strategy, the therapeutic strategy is based on this risk stratification. And so during the clinic, we will collect all this information, as certainly you all do in the adult, and then stratify the patients according to these different factors. So we don't have this 4 group of severity in pediatrics, because I think that the number of children are not sufficient to determine intermediate risk classes. And so we only have the green and the red, with the different numbers that may change according to the different series that are published. But that's currently what is in the guidelines. And then we will decide with this algorithm that is more simplistic than the one in adults. And as just said, the calcium channel blocker will be given to children who have a positive vasoreactivity testing, and then we will separate them in lower risk and higher risk. So today, in lower risk patients, we use mono or oral combined therapy with PDE5 inhibitors and endothelin receptor antagonist. So this is the very common treatment. There is no clear demonstration that mono or combined therapy is superior or inferior. And what is important is to do serial reassessment to see if you maintain the child in the low risk profile, as you do in adults. For the higher risk, today, we use very rapidly in children who have usually very severe pulmonary arterial hypertension. We use very commonly prostacyclin, either IV or subcutaneous, associated with oral combination therapy. The monitoring should be done exactly the same way, by assessing the same panel of data with clinical echocardiographic evaluation, NT-proBNP, and 6-minute walk distance in the children who can walk. And it is important to maintain the child in the low-risk profile, and this is the level of recommendation. So that usually what we do in the clinic is we assess WHO functional class. You may think that assessing functional class is difficult in small children, but with the parents and the child, it's very reliable with simple questions. So if you, of course, if you are in a high functional class and if you stay in high functional class, your outcome will be poorer than if you change your functional class for a better one. And it is exactly the same for the NT-proBNP values and for the TAPC, and these are the three treatment goals that we commonly use in pediatric PAH. So this is the table that is in the guidelines for the adult, and so we do all what I just said. And one of the questions is, should we redo right heart cath in children after initiating treatment? And it's a complex issue. We don't have a lot of data to have a strong recommendation, and this is a series that we have recently done in my unit. And it's counterintuitive, in fact, because if the child is not in the low-risk profile, doing bad, let's say doing bad, you should not do a cath. You should escalate therapy and put him in the low-risk profile. Don't redo the cath, because you will certainly have the information that the treatment is not sufficient. For the patients who are in low-risk profile at baseline, including the hemodynamic data, it is questionable to redo the cath if the child is in the low-risk profile. And so the situation in which we redo the cath is when the child has bad predictors of outcome at baseline and is with the non-invasive marker in the low profile, and we want to confirm that we have an effect on hemodynamics. But still, it has not been proven today that these are clearly, the hemodynamic values are clearly therapeutic goals. So the final question is, what is next? If the child is deteriorating while on triple therapy, then one of the options is lung transplantation. I'll just show you the data. They might not be completely updated, but they have not changed a lot. It is today, the pulmonary arterial hypertension is the main cause for lung transplantation in children. And you can see here, even if it has been reduced a little bit these past years, that the death on the list is very important. And graft failure and operative death are also important, with a median survival of about 9 to 10 years. So it is not, it is a good project, of course, for quality of life, but it is not really a long-term project for the majority of children. So there are alternatives. The first one that you, of course, you know in the adult population is ballooning or stenting or putting a flow regulator in the atrial septum, but this is not clearly feasible in children for an important reason is that right atrial pressure is usually low. So it will not work, except in children who are in overt right heart failure. So usually we don't use that. And the alternative is the pod shunt strategy. So you transform the child who has idiopathic pulmonary arterial hypertension in Eisenmenger physiology by creating a communication between the left pulmonary artery and the descending aorta. And the shunt will be from the left pulmonary artery to the descending aorta, preserving the oxygenation of the coronary artery and the brains. Of course, it is not a cure for pulmonary arterial hypertension, but in the POTS registry that we have done with many teams in the world, we have collected 121 patients. Of course, there is an early mortality in these children, but particularly at the beginning of the study. Now the mortality is much lower, and improvement is spectacular, as you can see on the bottom right of the slide, with improvement of WHO functional class, NT-proBNP, functional capacity, and we were able to wean from IV prostacyclin a high proportion of patients, even if it might not be completely logical to do that. I have two last slides. The first one is to define what is a pediatric PH center. The numbers, of course, are certainly lower than in the adult because the children with reversible PH will not be included in such a center. It is absolutely crucial to have a close collaboration with an adult PH center for sharing experience, because we will have interaction for the genetic screening in one way and in another one for the transition program in adolescent. It's also important to train a pediatrician for PH, to have a center with all the facilities and the appropriate environment as listed here, and to share also knowledge and programs with patients association. There are still many gaps of evidence. I just listed a few here. First, as I showed you, there are many genetic anomalies, but we don't know if they are important to stratify the risk. And I think that we should go in this direction and do big collection of patients to try to understand if there is specific treatment and specific outcomes according to the genetic mutation. To define the therapeutic target, is it sufficient to do WHO functional class, NT-proBNP, and TAPC, for example, or should we have other therapeutic target in children? How precisely adapt the treatment during the monitoring? When to do, for example, final strategy, POTS or transplantation? What is exactly the timing? I think that we don't have clear data for that today. And I will just mention at the end that we don't have so many patients with the group 2, but we start to have a couple of patients with SAPH in pediatrics, and it is also a problem, for example, in restrictive cardiomyopathies. And as I told you, there is a big developing group that is the group 3 with the lung developmental disease that has to be explored, but that has a strong overlap with the group 1. And so it's what you call with your comorbidities and the lung phenotype yesterday. I think we also have one in pediatrics. And I was very happy to hear yesterday, and I hope that you will have questions for me, because I will stop here. Thank you.
Thank you, Professor Ponet. You can join us. I think 3 very interesting talks, and I would think there will be stimulation for the floor to ask questions.
Thank you. Thank you very much for all speakers. My question to our teacher, Dr. Hussam. So we encounter sick patients in the ICU, especially sedative patients, to extent we can't send them to CT angio. If there is worsening in the pulmonary hypertension and there is no parenchymal process, would you recommend starting empirical thrombolysis with individualizing such approach indeed?
Well, I mean, thrombolysis in particular, probably not, unless you have another strong thought that this is leading to, the mechanism is a PE. Mm-hmm. Our patient, we did see DVT on him. Mm-hmm. There was the probability of this caused by increased PVR, by like some further PEs showering, although it's not big on the CT, was there. So the thrombolysis did make a difference in him because he was really living on a thin line. But you don't want to overdo it. If you have a very strong clinical and you believe this patient is having this, I would go for it as a life-saving. But again, we don't want to overdo it. Similar to what we practice in the ICU. You have to be a little bit, practice some wisdom in the pre-test probability. But I agree with you. You don't subject the patient to the risk of a diagnostic procedure if you can do it some other way.
And another question for Dr. Damien. Sometimes we see patients with pulmonary hypertension and PFO. So could this be a congenital heart disease, or we classify it as idiopathic with compensatory PFO?
Yeah, I think that the question is interesting, is that is atrial septal defect or PFO associated with PAH always coincidental? It might not be true. Yesterday we have seen a patient with sinus venosus. It has been clearly shown that pre-tricuspid shunt may lead to pulmonary arterial hypertension in the adult. But I think that my message is in children. It is not logical because it's not a long-lasting shunt. And so the association is rather due to genetic anomalies, and some of them have been identified, and I think that some will be in the future.
Three great talks. Thank you so much for the speakers. So let me follow up with this question. So how often you see congenital heart disease associated pulmonary hypertension in children? Because, you know, it needs long time to develop this. And what's the commonest type of PAH in children?
I'm sorry, I did not get precisely the point.
What is the most common type of PAH in children, and how common you see congenital heart disease associated pulmonary hypertension in children, given the fact that it needed longer time?
I mean, irreversible pulmonary arterial hypertension associated with CHD. I think that in countries in which you have screening for congenital heart disease by the pediatrician because they have murmurs or things like that, and if surgery is available, we have a very limited number of patients with pulmonary arterial hypertension associated with congenital heart disease because they are timely repaired. But still, even in patients who are repaired according to the type of shunt, in the literature it's about 5 to 7% of them who will develop pulmonary arterial hypertension later in life. So I think that we today, for some of these patients, it's exactly the same as for ASDs. They may have two hits. The first one is the congenital heart disease, and the second one is a variation in one of the genes of pulmonary arterial hypertension. So I will recommend in unusual evolution of pulmonary pressure, let's say, in these children, to screen them for genetic anomalies.
And what's the most common type of PAH in children you encounter?
Oh, it's the most common in my center. It's the most common is idiopathic, with 50% of irritable. And pulmonary arterial hypertension associated with congenital heart disease is very rare. But it's probably this proportion is certainly totally different in the planet.
Yes. Actually, second largest in our cohort is actually congenital heart disease, but I'm talking about adult PAH.
Yeah.
Yeah.
If you're not screened for congenital heart disease, then you're not timely repaired, and you will develop, and the children will develop pulmonary arterial hypertension. So I think that in European countries, Eisenmenger will become a very, very small population.
Yeah,
but we will have the majority of patients will have coincidental shunt.
Yeah. Can I have one more question? Sam, I like your talk as well as Raghda, of course, but Sam's talk is practical. We see this in our practice. So the question always when we round in our patients, having this fine balance between a patient who is having now overt right heart failure with hypotension requiring inotropic support, who has been already on pulmonary target therapy, including IV prostacyclin. So just for everybody to know, how do you keep this fine balance? And is your priority to give more inotropic support and withdraw the IV hypotensive drugs like treprostinil and keep the oral? Because you want to avoid the rebound, severe pulmonary hypertension, which give you in a vicious circle again. So can you tell the group about that, please?
So thank you, Abdullah, for this question. It's very common, as you said, sometimes difficult decision, but the priority should go to the maintaining the blood pressure. You don't compromise your blood pressure because it's like all these components will help the ultimate goal of improving the coupling. Yes, you are trying to treat the elevation in the PVR, and you are trying to improve the contractility, but at the end of the day, it's the interaction between the two. So the priority goes for the blood pressure. Once things become stabilized, you might be able to try to decrease it. Now, I won't de-escalate the pulmonary vasodilators at this phase. I would try to keep them. On the contrary, as the situation allows it, I would up-escalate the epoprostenol, if you wish. This is the most common agent I use in the ICU. Up-titrate it to a good dose where it will maintain the easy ventricle on the case. don't forget the other things, the preload and the afterload, because they are very important to maintain as well. And it's clear from what we see, sometimes you have to push to the next level. And I think you did have experience with people who required even an emergent transplant because they failed to improve with all of the above measures. So it's a continuum. Majority of the times you don't have to go beyond the even, like pulmonary vasodilator therapy. A lot of time things will improve if you manage to understand the physiology and act early. I mean, most of the time, by the time we get called for emergency room, they die, unfortunate. By the time they call us, it's advanced, the patient has been there for a few hours, been given a couple of liters of fluids, and it's a lost game. So again, hopefully the awareness amongst intensivists, ER physicians, you guys as a pulmonologist or cardiologist practicing PH, you probably should be more involved in the management of these cases. The current practice is that the patient in the ICU, they have to deal with it. The patient in the clinic, we take care of him. We know how to adjust the imacitintan. We can debate, shall we switch or not switch? But that's not the case when they become sick in the ICU. So I think we should be part of a multidisciplinary team that will make a decision because we do understand the physiology a little bit better than the intensivists in this case. And don't allow them to do rapid, knee-jerk reflex things because that can be harmful.
Hussam, in the same scenario, suppose the patient came before the sepsis, he was in low-risk patient, and then he lapsed into sepsis. We are obliged to reduce the afterload, and then the patient is improving on your drugs. This transition stage, how we are going to, are we going to continue in the IV therapy we gave, or?
This is again, I think, we have some international speakers. I see two of them on the mics. But this is something that out of necessity, I have been practicing this for many years now. We don't have an easy access to parenteral therapy outside the hospital, the ICU particularly. We do have it, but limited, let's say. The thing is, if you manage to identify the precipitating factor and you correct it, the down-escalating is not impossible in concept. If you talk to Naz, for example, he will not even listen to you. This does not exist in the Western literature about, there's no data. But if you really identify the precipitating factor, pneumonia has been treated, the patient is most likely will somehow with time improve. We give them enough time on parenteral therapy. We don't just turn it off. It's not an inotrope that you turn on and after 2 days you turn it on. We give enough time to stabilize the ventricle, and successfully we managed to get this done. Maybe out of practice and necessity, but it works, really. The crisis, once you control the crisis, probably you're lucky to go back into the baseline, which is sometimes not great. Sometimes this is the time to really up-escalate. But if there is a clear precipitating factor for this, managing this helps. Now, if it is a progression of the disease, and the patient came to the point where, you cannot really take them off, you'll have to make an active decision. Am I going to send them for transplant? Am I going to make them DNR? And that will end the game for them.
I want to congratulate you all on great talks. I must continue on with you, Hussam. Your talk was fantastic, but it was showing years of wisdom and experience. And I always think it's all that wisdom and experience. Sometimes you only have 1 minute to pass it on to a young doctor in the intensive care unit in the middle of the night, where you're trying to explain, don't intubate, or don't stop the drugs, and so on. Those sorts of things, you only have a short period of time often to tell them. And in fact, what you mentioned there about the prostacyclin for a short period of time, it's kind of what we do at ECMO, isn't it? We put people on ECMO, we get them over the sepsis, and then we take them off again. And because we can't keep them on ECMO for the rest of their lives, even though if they feel they can breathe on it. Same way with prostacyclin, there are times if you cannot give it to them long term, then you need to use it as a bridge to the next steps, whatever that might be, and then when they're well enough, come away from it again. But the only question I was going to say to you, I wonder what your go-to pressor is. When your back's against the wall and you're advising, you don't want them to be putting them on adrenaline infusions and so on and causing more pulmonary vasoconstriction. You said you don't have levosimendan, and I don't think there's much data on it, but what do you tend to go to? What's your one that you feel safest with?
Usually norepinephrine plus vasopressin is the common practice that we do in our ICUs. We definitely don't use phenylephrine because of all its negative consequences, and we try to titrate it according to the target. Intensivists are very familiar with this, and we're lucky because this is the most commonly used in sepsis patients. So any patient you go into the ICU, if they are really hemodynamically compromised, you will find them on norepinephrine and vasopressin. So life is easy for us because we are doing the same. We don't have any specifics. Now, dobutamine, milrinone, and the specific like inotropes are welcomed, but sometimes they cause hypotension. And in the very acute phase, probably it's not always the best thing to do. I'll try to introduce them as soon as I manage the, the blood pressure. And of course, we have to be worried about the tachycardic effect of them. But they can be good. Like in practicality in the ICU, I would probably rely more on norepinephrine than the inotropic agents alone.
Thanks very much.
Thank you for the session. And back to children. I was intrigued with the concept of HFpEF in children. And I wonder if those are the ones who have been undergoing cardiac surgery.
I cannot hear your question. But
so very simple. HFpEF in children,
yeah.
Is that the ones who have had surgery?
Yeah, part of them. Part of them have had surgery, particularly for left heart obstructive diseases, such as coarctation, aortic stenosis, etc. But the majority of them are restrictive cardiomyopathies.
Okay, but so you wouldn't imply that cardiac surgery itself is, because we have looked at an adult cohort and we found a high prevalence of this left ventricular filling pressure elevation in the ones with ASD closures, also right heart surgeries.
No, we haven't found that. In a recent series, we found mainly patients who had left heart disease, as I told you. A few indeed had other congenital heart disease, such as tetralogy with a restrictive behavior of the left ventricle. So certainly it does exist, but the confirmation of the hemodynamic is not always is not done. I mean, as a routine procedure. So usually the children come with the symptoms.
Well, thank you.
Or they have an hemodynamic evaluation for other purposes, and then you're surprised. So probably the prevalence might be higher in the large population of children operated on in early infancy, but I don't know exactly.
I'm very interested in the consequences of surgery, because I do see in many adult patients very severe HFpEF features, also in bypass and aortic valve disease, but it's never possible to dissect from the underlying condition. But in children, it may be easier.
Yeah, and potentially we don't have the complete figure because we don't have the sufficient follow-up. Because maybe if you follow young adults, you may not see that, and then it may develop that later in life. So certainly, it's an advice to follow them for this purpose.
Thank you.
I think if you allow me, Prof, I think the best example of HFpEF in kids are those patients who had what's called borderline LV. So they have Sean complex, or they have mitral aortic co-arc, or even sometimes you have endofibroelastosis intrauterine. And then unfortunately, when they are born, it's underestimated. They are pushed for surgery. They convert them to two ventricle surgery, and they think their subaortic LV is not carrying the circulation. I think they are the best to resemble the HFpEF in adult. We see them, sometimes they stuck in ICU, sometimes even, I mean, they might not complete their first birthday. Yeah.
So thank you so much for all the speakers. So I have two questions, one for Dr. Hussam and the other one for Dr. Raghda. So for Dr. Hussam, there is we receive a lot of questions from our colleague in the ICU that there's a patient with pulmonary hypertension, not diagnosed in the past, and you can prove it that there is no pulmonary hypertension based on the echocardiogram, like few weeks, patient admitted for other reasons, a few months and is just presented right now with elevated RVSP in the ICU, and you can prove that there is ARDS. So we receive a question regarding should we use nitric oxide and whether the use of targeted therapy. That's the question for Dr. Raghda. What do you think about, I'm asking the reverse question. Instead of screening for high-risk population, at time of diagnosis, should we screen them for HIV, for portal hypertension? So would you like to go through all the workup, or just go target to some like high clinical suspicious?
Thank you, Shaya, for the question. Very common practice, similar to anybody else that gets referred to the clinic because of abnormality in the echo. So I would be very cautious in labeling people having pulmonary hypertension in the context of the ICU if they don't have the context of pulmonary hypertension. ICU environment is not very good in terms of a fluid. Any situation that makes you overloaded, the right ventricle will not look good. Most of the times that they are in the ICU, they have a primary pulmonary disease, whether it's a bad pneumonia or ARDS secondary to sepsis or primary ARDS. And these cases, definitely I will not count them as pulmonary arterial hypertension yet. The physiology that I discussed, it applies to people who have other diseases that can influence the right ventricular failure and function. So I think the trick will become, what do I do now? You can follow kind of similar guidelines to what we mentioned for pulmonary arterial hypertension, but establishing the diagnosis, it is not very wise. Now, Rayan Sa'al about if you really don't have the proper workup to really establish pulmonary vasodilator therapy, we do that all the time. But we do have a pre-tested probability. We have a very strong belief that this patient has pulmonary hypertension. The NO data in ICU environment is there. It improves oxygenation, not in everybody, in some of the patients with ARDS, but it does not affect mortality. Some people are fans of it, some people are not. In the US, in North America, in Europe, you're not allowed to do this simply because it's very expensive. In our part of the world, they give it chances, they try it. In adults, I say, in pediatrics, there is room for NO in the ICU for kids with ARDS. But in adults, it's a trial. If it fails, probably we should turn it off because of unnecessity, cost, and the potential side effects. So again, it's a balance. If you really think this patient has pulmonary hypertension that requires intervention, go ahead and treat them, establish the diagnosis later on once they are stabilized, and we did this many times. And or you just have to follow the same physiologic mechanisms until you really look for the proper way to diagnose them and treat them.
Okay, so I think the question from Dr. Shaya is about if you have somebody has probably pretty much group 1, would you are going to screen them for portal hypertension, risk of HIV and all that. So if you have somebody has PH group 2, group 3, it's clear what to do. So if you have possibility of PH, so I guess the guidelines tells you it's group 1, it's actually recommendation 1A to send for blood test, to send for immunological studies, hematological studies, and to do HIV. And it's class 2A to do ultrasound abdomen to look for portal hypertension. So I guess it depends on presence of risk factor. For example, when I was in my center in London, Ontario, my professor never actually ordered HIV testing on patients unless there is risk factor, because he did it for a very long time and never get back positive results. So I guess it depends on the risk factor of the patient. I personally don't do HIV in all my patients unless I suspect it or I have risk factor. But I have come into encounter of patient referred to me once time, diagnosed with PH idiopathic. And unfortunately, after seeing her for a couple times, she had low platelets. I couldn't explain it, so I did an ultrasound, and she ended up having portal hypertension related disease. So I think the guidelines tells you do it. I think you should do it, but again, based on your physical exam assessment and risk factor in the patient.
So the last question.
I wanted to congratulate you on your excellent talks. My question to Damien. I'm a pediatric pulmonologist, and most of the cases we see are actually group 3 cases. And unfortunately, they are diagnosed based on echo only in other centers, and they started even on double or triple therapy. My question, what do you think the best way to de-escalate if the lung status improves?
It's a difficult question. We have not seen, except in pulmonary bronchodysplasia, we have not seen so many children with severe pulmonary disease and pulmonary hypertension. But usually, yes, we stop the treatment, if this is your question. But I'm not aware of some, at least in my institution, for interstitial lung disease, they may have pulmonary hypertension, but usually we don't treat them.
Yeah. I don't like to treat them, but I'm saying if they're already on treatment and they're taking double or triple therapy, which ones to start with, or you just stop all of them at the same time? What do you think the best way to be?
I don't have an experience of that. I think I've seen only one child who received triple therapy for pulmonary hypertension associated with lung disease. So I don't have a clear opinion on that. We do screening for this patient, and it's completely exceptional to find high pulmonary pressure. So I'm sorry that I don't have a clear answer for that.
I might comment, we see that in adults as well. A patient was misdiagnosed based on an echo, for example, and they ended up having a pulmonary disease or left heart disease. So you should stop the therapy. Now you do it probably sequentially. Start with the more difficult one, the more expensive one, the one that is more likely probably risky. But eventually I think we should keep pushing to stop all therapies when they are unindicated and unnecessary.
I took the permission to have the last question for Dr. Ragd. Do you think, depending on symptoms in patient group like scleroderma, because I usually found them, they are symptomatic. And when you ask them, it's merely maybe unconditioning, you know, it's not a chest disease or something, but why don't we apply the detect for even symptomatic patients? Is there any data that came negative with detect applied for even symptomatic patients, rather going directly to the right heart cath?
Okay. So I think DETECT is mainly screening for asymptomatic patient. I haven't read that DETECT was actually toward symptomatic patient, because the idea of the DETECT that if they have scleroderma more than 3 years, DLCO is low, vital capacity is maintained, and they have the phenotype that we talked about, then we need actually to screen them early with echo, look at certain parameters, and then if they made this, then they go to step 2 and then to the right heart cath for earlier diagnosis. We heard yesterday from Professor Gallet that we actually want even to look for these people who have mean pressure of 21, 24, because even if the guidelines doesn't tell you yet to treat them, we know that they're going to develop the disease and they're going to need PH therapy because they progress quickly. So the one that they're symptomatic, they usually need to be investigated, especially if you don't have an explanation of their shortness of breath. If they end up having ILD, if they end up having other reason, yes, but I'll be aggressive on detecting them. I'll be aggressive in doing investigation. And I think exercise testing is not a bad idea. CPET is amazing in this group of patients to help guide you whether to send them to the right heart cath or no. So I think that's my answer in terms of like, but I'm not sure whether there is negative outcome of detect in symptomatic patient. I don't believe so. But I think in symptomatic patient, we have to be aggressive because they are they're the highest of risk factor of developing PAH out of all the groups.
So thank you for everyone. Again, we will be leaving for 15 minutes. We'll return back at 11. And again, everybody is invited to join the lunch after the last session. It will be in the same place. So thank you for everyone.
clear? Not clear. Is it clear now? Yeah, it's good. Good. Thank you. Okay. Louder. Is it clear? Yeah, great.
Hello, check. Hello. Hello, check. Hello, hello. Hello, check. Hello, hello.
month 10 of the COVID lockdown.
Good morning, everyone. I'm Dr. Bedr Al-Zahrani. I'm an interventional cardiologist at Prince Sultan Cardiac Center. It's really a pleasure and honor to be here chairing this last session of our conference. It's really a pleasure and honor to be with Dr. Saleh Al-Dammas, who's a pioneer in the field. We're going to have a 20-minute talk for every presentation. We'll leave the questions and the discussion till the end. It's a pleasure to introduce Dr. Hanan Fan. Dr. Fan is a pulmonology consultant. She's the head of Division of Pulmonology at the King Fahd Armed Forces Hospital in Jeddah, and she's going to talk about chronic thromboembolic disease without pulmonary hypertension.
Thank you for the introduction. Thank you for the organizing and scientific committee for inviting me. I'm so delighted to be here with you and talk about chronic thromboembolic disease. So our sessions will be talking about pulmonary embolism. As we all know that it is a well-known killing disease with high mortality. It is common. Many cases post-mortem found to be due to PE, and the incidence has increased lately due to COVID. We used to talk about PE, acute management, thrombus resolution, prevention of recurrence, and anticoagulation, but lately we are more concerned about the long-term sequelae. The majority of patients resolve the acute phase of the PE, but many patients experience chronic dyspnea and exercise impairment years after the acute event. So such patients, what we think about and we have to investigate is about SAPH. SAPH is a specific type of pulmonary hypertension. As you all know, it's group 4 in the classification of pulmonary hypertension. It is due to the occlusion of the subsegmental, segmental, or larger pulmonary artery due to organized thrombus, post-embolic fibrotic material. I know that the coming presentations, they will extensively cover about the SAPH, but what is worth mentioning here, that it is important, it is life-threatening post-PE complication, but is it the only issue we think about in patients with chronic dyspnea post-PE? So before starting my presentation, I would like to tell you a quick, brief presentation of one of my patients. She presented to ER, 32 years old, gravida 3. She was pregnant in her gestational age of 2 months. She presented with PV bleeding. At that time, she was hemodynamically stable and referred to OB for abortion. And then suddenly in ER, she arrested. The workup showed echo and labs, ECG suggestive of PE. And her CT, can you just turn, showed bilateral PE. She was intubated, thrombolized, and discharged on apixaban. 3 months post-PE, seen in pulmonary clinic, patient complaining of exertion and shortness of breath, exercise limitation. She completed 3 months of the anticoagulation. We repeated her echo. The study was technically difficult. This is the report of the echo, though it showed RV moderately dilated, but there was no clear tricuspid regurg, and the RVSP was normal. The other all workup screening of the thrombophilia, connective tissue disease workup was negative. So during this time, we had the option of either repeating echo because it was suboptimal, or we could just consider that there was RV dilatation, so we went ahead to do VQ scan, which showed moderate perfusion defect. And the 6-minute walk test patient has exercise limitation. So at this time, she received already 6 months of anticoagulation, but yet she was symptomatic with RV dilatation, exercise limitation, and perfusion defect. So at this time, the usual thing you would think about CTEF, impressively, her right heart cath was normal. So the pulmonary capillary pressure was 12, and the mean pulmonary artery was only 11. And the repeat CT, can you please play it on? A complete resolution of the thrombus. There was no even evidence of CTEF reviewed by chest radiologists. There was no signs of radiological signs of CTEF. So at this stage, patient has no pulmonary hypertension, but she's symptomatic. So what do you do at this stage? So there is a wide range of potential outcomes after PE. So is it deconditioning or an anxiety? Maybe other patients have cardiopulmonary conditions, other coexisting conditions, advanced age, obesity, anemia, active malignancy, or is it residual pulmonary vascular occlusion, or to the extreme of CTEF? So these all need advanced, expensive diagnostic workup. We really need to have stepwise systematic approach. So we had this paper by Sanchez in 2010, where he studied the probability of perfusion defects after PE. He had 254 patients who all received 3 months of anticoagulation post-PE. He had a VQ echo for these patients, which found that 30% had perfusion defect, 5% only had CTEF. And also, interestingly, that he linked the pulmonary artery hypertension with the perfusion defect. And he also studied the thrombophilia and the other risk factor. I don't know, is it clear or not? Sorry for that. But the risk factor showed age, previous VTE, and time from first symptom to diagnosis, initial vascular obstruction. So these were independent predictors for perfusion defect post-PE, irrespective of the choice of anticoagulation. There's another study 2 years after for the residual pulmonary thromboemboli, which showed similar data, which showed about 30% of residual thrombi, 70 to 80% complete clearance. And again, they have linked the hemodynamic changes with the physical performance and quality of life. Later on, there was a new concept for PE syndrome, post-PE syndrome. Although the usual thrombus resolution will be 50% after 4 weeks, and then 70 to 85% will resolve within 6 to 12 months, but 50%, half of those patients have functional limitation and persistent shortness of breath, which includes only 0.5 to 4, maximum to 11% of CTEF. So there are significant percentage where the patients are symptomatic and not CTEF. So it is a spectrum of presentation post-PE. Once the patient presents with acute PE, the extreme end is CTEF with pulmonary perfusion defect with pulmonary hypertension. But in the middle, which is more common than the CTEF itself, you could see the patients with persistent dyspnea having perfusion defect, but no pulmonary hypertension. either with exercise or just with persistent defect. So this is a simple diagram to show the big circle is all the PE, and the smaller one, which 50% having persistent dyspnea. CTIF includes very small circle, and the other two circles is the CTED, which means perfusion defect, but no pulmonary hypertension. One with only persistent thrombi for the perfusion defects, and the other one is with the persistent thrombi. Okay, so we wanted to see the underlying pathophysiology and how to treat them. Are they similar to CTIF or not? So it was a variable penetrance of several factors, which includes impaired fibrinolysis, intrinsic patient factors, thrombus characteristics, induced hypercoagulability, and abnormal thrombus remodeling, dysfunctional inflammatory response. These inflammatory response triggered by the shear stress on the myocyte. So the myocytes and increased afterload will lead to RV dysfunction, and at the end will cause post-PE syndrome and CTIF. So these are the factors we have mentioned: previous VTE and recurrent VTE, plus the inflammatory conditions like the antiphospholipid syndrome and the VA shunt, splenectomy, inflammatory bowel disease, malignancy, because any alteration in the inflammatory response will lead to scar formation rather than thrombus resolution. And this is, again, the difference between the CTED and CTIF on the RV-PA coupling, where the CTIF has pulmonary hypertension even at rest due to the small vessel involvement, while CTED mainly probably related to the obstruction itself. So can we treat those patients like CTIF with the pulmonary endarterectomy to resolve this obstruction? So to know about that, we have to know the underlying functional characterizations of patients with CTED. So this is a good study that included 79 patients who included 10 patients CTED, 31 CTIF, and 41 controls. These control patients who had shortness of breath due to other causes, not with the perfusion defect. So it has been shown that CTED patient, which is the middle group, reduced work rate and reduced oxygen consumption. These are the components, the cardiac components and the ventilatory components. So patients will have during exercise. So let me just explain. So the typical response to exercise, you have two components, the cardiac and the ventilatory response. So during the ventilatory response, you need to have reduced dead space. But in those patients will have increase in the dead space. And gas exchange defects. What's interesting to see is that the characteristic of CTED patients, the limitation similar to the CTIF compared to the control patients in all parameters, in the work rate, in the cardiac response, reduced rock volume augmentation, and in the gas and the ventilatory inefficiency. So talking about the right heart cath, the hemodynamic, are they similar or not? So you could see this column is CTIF patients. These are CTED, these are control. So in CTIF patients, of course, there's pulmonary hypertension with normal wedge pressure. CTED have normal parameters. What characterizes CTED is during exercise. So they have abnormal hemodynamics during exercise comparing to control. So what's the idea of the exercise test? So this is the stress test. As you know, it is done right heart cath during exercise. So usually you could do it bicycle ergometer in upright position or lying, but lying is the preferred because of the zeroing of the right heart cath. So this is the preferred patients under certain conditions in cath lab with the cycle ergometer. And they have increments, symptom-limited increments of the exercise. So this is a very crucial test where it can show three things, three processes. It can differentiate between one of three processes. Either exacerbation of underlying cardiopulmonary disease or any of the two, the one I mentioned, either the ventilatory inefficiency and the increase in the dead space, or it's the cardiac limitation, the decreased stroke volume augmentation. So again, this is the cardiac component where during exercise, the normal response during exercise, there will be increase in the cardiac output. So when there will be increased cardiac output, it will increase the pulmonary vascular flow. But because of the distensibility, it will adapt. So it will stay in the shaded area. This is the normal response, 1 and 2. But in these patients, because of the inability to adapt, because of the defect in the distensibility of the pulmonary artery, so there will be more steep response and pulmonary hypertension of the mean pulmonary artery pressure more than 30 during exercise. This is a study where the outcome of pulmonary endarterectomy for these patients seated. This is a study where it included 42 patients, and the result was impressive in line of the functional class, the dyspnea, and the 6-minute walk test exercise limitation improved after pulmonary endarterectomy in this group of patients seated, and quality of life score. This is a better study because that study did not do pre and post exercise test. This included 32 patients where 12 of them had exercise right heart cath before and after the surgery. Again, it showed good response in terms of the total pulmonary resistance and the mean pulmonary artery over cardiac output slope, and in the, you could see the difference between before and after, and the symptoms as well. So the PEA had showed in highly selected patients who are operable seated showed improvement in their quality of life. What about the balloon pulmonary angioplasty in inoperable patients with seated? It's very limited. Only what I found is this published by Wendenroth. He included only 10 patients. The 10 patients, not all of them was statistically significant in terms of 6-minute walk test and BNP. Only 6 out of 10, 7 out of 10. But the symptoms really was significant. So it reduced the symptoms. But yet, this is a very small group of patients, and they did not have control patients to compare with. So it is really still challenging, and the optimal treatment is still a matter of debate. And it depends on the natural history of seated. Is it a way, and the seated will end up with, it's a step before the CTEF, or is it a separate pathophysiology? Still need to verify further. And even those studies that have been done, the PEA for highly selected group of patients, which are operable, and the balloon pulmonary angioplasty is still only one study in a small group of patients. So I will just end my presentation with 2 slides. This is the stepwise approach, where you could follow for those patients after the acute event of PE. You start with those patients who are symptomatic, of course, received 3 to 6 months of anticoagulation and still having symptoms of persistent dyspnea. The first step to do is transthoracic echo. From there, If the echo showed evidence high probability of pulmonary hypertension, then it goes to the PH center and SAPH, and you refer to the next two presentations, they will talk about it. But if the echo did not show low risk for PH, then it depends on the CT pulmonary angio or VQ scan. Pulmonary angio, if positive, that means a patient has perfusion defect with normal pulmonary hypertension. So it's likely CTED, and then you do the invasive, the exercise testing, and the further, as I discussed. And if it is negative, you do VQ scan. The VQ scan, if it is positive, it's post-PE perfusion defect, the ventilatory inefficiency, and so on. Usually these, you continue on anticoagulation, and if it is negative, it is post-PE breathlessness, deconditioning, or anxiety-related. You just need to rehab. So in our case, she was symptomatic. She received the 6-month anticoagulation. Echo showed RV dilatation, questionable, not that, so it's suboptimal study, so you can consider it here. And then the CT did not show any remnant of the obstruction. Then the VQ scan was positive, so it was just the perfusion, the inefficiency, the perfusion defect. So we kept her on anticoagulation so far. So regarding the anticoagulation, yet it is not clear. There are no clear recommendations like the CTEF to keep them on lifelong anticoagulation. Still more data needs to clarify that as well. So take-home message. As Dr. Raghda mentioned in the guidelines, it is guideline 1C, is to investigate all those patients who are symptomatic post-PE, not only for CTEF, but you should thoroughly assess these patients, including CTED, of course, and other differentials. Early detection of function-relevant incomplete thrombus resolution vascular obstruction is favorable and could help to achieve an earlier diagnosis and treatment. So it may help us a step before reaching the CTEF. Improve operative outcomes, but yet the other medical treatment and further investigations and treatment needs to be there. But just one last point to mention, you need to refer to PH center. Any case with CTED, CTEF is to refer to a specialized PH center for management. Thank you.
Thank you very much, Dr. Hanan. I think we'll leave the questions towards the end of the session. Come and join us here, please. And before I invite the next speaker, Hassan asked me to make a couple of announcements. Lunch will be served immediately after the session at the same place. It's not written in the program. And to get your CME hours, you need to fill out the evaluation form at the end of the session so you can get the CME hours. And the last announcement for those who are interested, there is an ongoing workshop on 6 minutes walk test next door, especially for respiratory therapists. If you're interested, it is ongoing right now. And now I'd like to invite our next speaker, my dear friend, Dr. Faiz Al-Ahmadi. Faiz is a pulmonary hypertension consultant, pulmonologist at King Faisal Specialist Hospital in Riyadh. He had his training in PH, particularly in North America, but then he did something different. He went to Japan, and he joined the group that does most of the interventions, particularly balloon angioplasty in PH. So he will talk to us about medical treatment of chronic thromboembolic pulmonary hypertension. Faiz?
Assalamu alaikum. Good morning, everyone. Thank you for the organizing committee and for giving me this opportunity, and thank you for having me here today. I've been asked to present about the medical management of CTEF. Here is my disclosure. So basically, my talk will be divided into two parts. The first part, I will just review the already published literatures, and then the second part of my talk, basically, I will review with you and share with you the new approaches for discovery of new drug targets in CTEF. So once you have a patient diagnosed with a CTIF, you will commence such patients on anticoagulation, lifelong anticoagulation. Then you will basically refer to a pH expert center. And in the pH expert center, usually we do an MDT meeting, including pH experts, radiologists, surgeons. And it's really simple if the patient is operable, so this is a straightforward for pulmonary endarterectomy. If not, then you have the option of medical therapy or balloon pulmonary angioplasty. The other possibility that after the surgery, the patient might end up with recurrent pH or persistent pH post-endarterectomy. So again, you have a choice of either medical therapy or balloon pulmonary angioplasty. So the question why we give medical treatment for, basically it's mechanical obstruction problem. So the answer is basically for the microvasculopathy. So when you have a proximal disease, Looper disease, so this is for pulmonary endarterectomy. Then you have in the segmental and subsegmental, you have a choice of balloon pulmonary angioplasty. However, to treat the microvasculopathy that being associated with the CTIF, you have to do medical treatment. I will leave them, this details the multimodal approach for CTIF for Prof. Irene Lang. So in terms of anticoagulation, this paper's from Prof. Mark Hempert. So they reviewed the patient who were treated by NOACs versus vitamin K antagonist. Overall, there was no difference in terms of the hemorrhagic events between the two groups. However, patients who were treated with NOAC, they tend to have more embolic events, though the number of events were small, but patients who were treated with NOAC, actually, they tend to have more of recurrent embolic events. This is why I prefer vitamin K antagonist in all CTIF patients. So this table summarized the randomized controlled trials of pH targeted therapies in CTIF. So RACIG-WAT in just one trial being studied by Prof. Ghofrani and his colleagues in a multi-center double-blind phase 3 trial. They recruited around 261 patients to either RACIG-WAT or placebo for patients with a CTIF or inoperable CTIF or patients with persistent pH after pulmonary endarterectomy. Actually, RACIG-WAT showed significant improvements and achieved the primary endpoint with improvement in the six-minute walking distance by almost 39 meters. However, no improvement in the placebo group, and actually there was a decline by 4 meters in the placebo group. So RACIG-WAT, it was FDA approved. In a CTRIF trial, subcutaneous treprostinil was examined. Again, similar cohort of patients with inoperable CTIF or persistent pH after endarterectomy. So around 108 patients assigned to either high-dose subcutaneous treprostinil, 30 nanogram, or low-dose subcutaneous treprostinil. And again, it showed significant improvement in the primary endpoint in the 6-minute walking distance in the high-dose subcutaneous treprostinil with improvement around 45 meters in the high-dose treprostinil. Again, in the CTRIF trial, it showed improvement in the other hemodynamic parameters and improvement in the decline of the PVR by 227 dynes. MERIT-1 study, again, Ghofrani and his colleagues studied the macitentan in inoperable CTIF, around 80 patients assigned either to placebo or to macitentan. So again, it showed the primary endpoint was improvement in the PVR, which was achieved. And again, it showed improvement in the 6-minute walking distance by a difference around 34 meters between macitentan and the placebo. What about Selexibag? This is a recent trial from Japan, actually. They studied Selexibag, similar cohort of patients, patients with inoperable CTIF, persistent PH after endarterectomy. And, but here in this cohort, actually, they added patients who has persistent PH after balloon angioplasty. So the primary endpoint at week 20, it showed a decrease in the PVR between the Selexibag group and placebo. So the recent ERS stated that Trisiguat and treprostinil are approved for patients with inoperable CTIF or persistent or recurrent PH after endarterectomy. And other PH medications have been tested in CTIF and are used off-label. Oral combination therapy is a common practice in CTIF patients with severe hemodynamic compromise. And with the withdrawal of PH medications, usually considered after successful BBA or PEA. So what about bridging patients with medical therapy, bridging to PA? So this study published 2 years ago, and overall they have reviewed two types of patients who were on supportive therapy with anticoagulation and Lasix, and patients who are on targeted therapy, namely ERA and BDE5 inhibitors. So overall, there was no survival benefits between the two groups. However, when they sub-analyzed these cohort of patients with the sickest patients with severe hemodynamic compromise with cardiac output less than 3.7, they found a 1-year survival benefit for patients who were started on targeted therapy prior to PA. But unfortunately, they noticed here, and this is the downside sometimes, the targeted therapy actually delayed the surgery for 7 months. So if you have the surgeon around, just go for surgery. So again, the ERS stated that there is no convincing evidence that preoperative pharmacological treatment is beneficial in patients with operable CTIF. Nevertheless, targeted therapy as bridging therapy for PA is sometimes considered in selected high-risk patients, and this should be discussed in an MDT and in expert center. So really the question now, how do you end up having this acute PE going to this chronic PE, and what are the underlying process and that explain this? So as we all know, the major risk factors for VTEs are the thrombophilia, the large clot burden, previous malignancies. However, in addition to that, we have what we call it a small vessel disease, and actually you can see this in the whole pulmonary vasculature in the arterioles, venules, capillaries, and big arteries. So you will have like a remodeling that is kind of similar to what you see in the pulmonary arterial hypertension. So this is a paper by Rosenquark, and he tried here to identify the different lesions in the CTIF thrombus and samples, and they found histopathologically, they found actually significant intimal remodeling, so like in new intima. Then they have a second type of the CTEPH thrombus, a second lesion, which it's atherosclerotic lesions with highly inflammatory markers. They found actually a thrombotic lesions with acute thrombus. And finally, they have a chronic, you will have a chronic thrombus with a lot of fibrosis and recanalization. So, when they reviewed the patients, they found that in that paper, they found the new intima. It's the major type of lesions that been observed in the CTEPH. And you can see here type 1 patients that are the patients with, I would say, proximal lesions. They found that the most common type of lesions is the thrombosis and acute thrombosis. However, folks with distal lesions in type 3 lesions, they have mixed lesions with thrombosis, recanalization, and atherosclerosis. So this is really a nice work published back in 2010. Here they tried to isolate the cell more and more, and they tried to identify the specific cells that participate in the chronic thrombosis. So basically what they did, they took the PTE samples and they make it like they culture it. And so they noticed different type of cells here. So you have the elongated cells, then you have like flattened and like cobblestoning appearance cells. And finally, in the chronic thrombosis, you will have a colony, they call it colony formations, CTEPH cells. So again, Quark, they found in the CTEPH PTE samples, they found a lot of immune cells with the B cells, T cells, macrophages, and neutrophils. So the last few slides of my talk, I will share with you a new technique used by Duke University. So they call it single-cell RNA sequencing workflow. So this cartoon actually, it's from Wikipedia, but it's shared the same idea. So basically what they did, they took a sample, tissue sample from the PTE sample, in their case. So then they did the dissociation of that tissue sample, and they get single cell suspension. Then they tried to isolate the RNA, and after that they did sequencing, a relatively new technique to more identify the specific cell types in the PTE samples. So again, from the Duke paper, they found that the lesions, as we said, they found thrombosis with high inflammatory cells. And here with another stain, they found a chronic thrombus, with recanalization and fibrous tissue. So this is a single cell atlas of CTEPH. As we mentioned, they found a lot of smooth mesenchymal cells in the smooth muscles, T cells, endothelial cells, macrophages, and monocytes. So just to summarize that part, when you have an acute PE, that you will have an injury of the vessels. Some patients, as you know, will have that PE, will not resolve. That recruited the inflammatory cells and play a central role in the propagation of the injury and modulation of the smooth cells. So in the acute thrombus, you will have a lot of platelets and robust of RBCs. However, in the chronic thrombus, you will have a lot of macrophages, T cells, and natural killer cells, which actually that modulates the endothelial and smooth muscle cells. So the question here, can we have a target for these abnormal cells in the CTEPH thrombus? So what did they found in Duke? So as they reviewed this single data after the new technique, and they tried to find a markers or a specific receptors. So they found a factor 2 receptors, which it's well known as PAR1 receptors. So these receptors can be expressed mainly in the platelets, smooth muscles, myofibroblast. So it's a receptor for thrombin. So when the patient is exposed to thrombin, the thrombin will cleave this receptor and activate this signaling through these receptors. So by targeting this, as you can see, thrombin actually causing more proliferation of the smooth muscle cells and more migration, and by inhibiting this receptor by PAR1 receptor, they call it Vorapaxar, it's maybe a target for CTEPH treatment in the future. So take-home points, CTEPH thrombus consists of typical vascular cells, but also populations of immune cells, and phenotypically modulates smooth muscle cells. And cells derived from CTEPH thrombus have defects in the angiogenesis and proliferation. There are many similarities in the remodeling process between atherosclerosis and CTEPH. Riociguat is recommended for symptomatic patients with inoperable CTEPH or persistent PH after PEA. And in patients with inoperable CTEPH, a combination of nitric oxide pathway ARAs or prostacyclin analogs may be considered. And by this, I end my talk. Thank you.
Thank you so much, Dr. Faiz. Well done. It's my pleasure to introduce the next speaker, Professor Irene Lang. Professor Lang is a clinical cardiologist and professor of vascular biology in the Medical University of Vienna. And she's going to talk to us about the complex approach of CTEPH management. Professor Lang.
Well, thank you for the invitation and your extreme kindness and hospitality. I think I'm the last one to say that here today, and I'm very pleased to be here and speak to you about CTEPH because it's a very good topic. It has evolved extremely well over the years, and I think if we gain a good approach to the treatment, thank you, we may be able to cure them. So this is my hospital, and my room is here. That's my conflicts of interest. So we are talking about chronic thromboembolic pulmonary vascular disease. You may know that the terminology has changed a little bit, with and without pulmonary hypertension, and it's in the group 4, which is PH associated with pulmonary artery obstruction. As a stimulus, I'd like to show you a pulmonary angiogram of a patient with typical segmental vascular lesions, I think, a great example of a CTEPH patient. And this is also very important. It's a push-forward OCT angiogram published in the European Heart Journal that is, I think, a very good way to make understand chronic thromboembolic pulmonary vascular disease with material that is obstructing the regular flow in the artery, causes a lot of turbulence, stop flow, again in situ thrombosis. And this is the target of treatments. But let me look a little bit more deeply into treatment targets. They're shown here. It's any level of the pulmonary vasculature, and the respective treatments are shown on this far end here. This pulmonary endarterectomy did it all in the past. Then came the medical to treat, and was nicely shown by my colleague before, probably the small vessel component. This is what we think. at least the vasoconstrictive component, you may also call that. And then came BPA, balloon pulmonary angioplasty, developed by Japanese interventionists since 2012. And it was a 10-year period up to today that they've really optimized interventional techniques. So in my presentation, I will talk about all three and how we place them in the treatment algorithm. You've seen this. The multidisciplinary team is really key because there are three treatments. There is pulmonary endarterectomy, medical, and BPA. How do we put them together for our patients? And I cannot emphasize enough the multidisciplinary team. And as a good illustration, I've taken this image from the Bad Nauheim group, where the multidisciplinary is probably very nicely shown in the collaboration in a hybrid room. This is like the cardiovascular dream, to have a hybrid room where everybody gets along well with each other, where there is a surgical and an interventional cardiologist active. And you see all the other components, including the patient. I haven't put that, the patient perspective here clearly. The clinical nurse specialist may be representing that in this slide. And you see the multimodality imaging, the multimodality intervention based on a multimodality team decision. And to make it really simple, I put in a red box with pulmonary endarterectomy, angioplasty, medical therapy, and multimodality. And of course, pulmonary endarterectomy is first. The evaluation, is my patient suited? And there's a number of components that contribute. It's, of course, multi-valent components. There's no adjudicated risk score directly for CTEPH today, but it will develop. And I would like to highlight the mechanical issues, lesions, and hemodynamics. That's very important, also for the surgeons. And a good surgeon knows about PVR and about how lesions contribute and what the relation between these two is. And it's about the distality, how far distal. It's about the load. It's about the types. The total occlusion versus stenosis doesn't matter to the surgeon as much as it matters to the interventionist. A total occlusion in coronary is a high-risk intervention. And it may not work, but in the lungs, it works very well. Peripheral hypoperfusion is a signal that was discovered by the French group. It demarcates higher risk. If you don't have perfusion out to the pleura, it is believed that that indicates more peripheral disease. Regarding comorbidities, it's very clear if you can't access the pulmonary artery easily, if there's a persistent vena cava or some venous abnormalities, that may be hard. Renal function is an issue for the interventionist, right ventricular function, hemodynamics is coming back again, it's also systemic hemodynamics. And then the associated medical conditions. And recently, sex has been shown to be a predictor of outcomes after pulmonary endarterectomy. This has been shown and will be published by the Canadian group of Mac Duperreau. Females do worse. So this is an old paper that I published with Diana Bonderman, and it illustrates that associated medical conditions, which there are, splenectomy, Crohn's disease, inflammatory conditions, thyroid replacement, they impact survival. If you look just on the right panel, if you don't have those, regardless of treatments, you do better. And then the other one is recently recognized that elevated filling pressures, as they occur in at least 10% of patients with chronic thromboembolic pulmonary hypertension, they do affect prognosis. And you see that here with a threshold of 15 according to the guidelines. And then you may set different thresholds, and if we use end expiratory rates, it's becoming even worse. You have more patients with this condition. So what is the evidence for our treatments? And I'd like to walk you through, and having in mind the weighting of the evidence you will make the best decisions. So first of all, pulmonary endarterectomy, we have to talk about this. It's a major surgery, but it's very successful. And this is just an example from the International SAPH Registry. You do really well. If you have a good surgeon, please ask him to operate. But as you can see, this is also from this registry that was published in 2012, we really miss out on 50%. And when I started to work in CTPH, I knew that half of the population that I was taking care of, I couldn't really offer anything. And in addition, we found that anywhere between 17 and 50% of patients had recurrent pulmonary hypertension after pulmonary endarterectomy. And this is the overview of the studies with their respective thresholds of definition. It's not so clear what is post-PEA-PH. You've seen the medical treatments. This is the randomized trials that have been done. And you see the change in PVR over here and the change in mean pressure. And keep in mind that you can change PVR by 20% and the mean pressure by 7%. And then came BPA, and I really changed my life. I feel like I was dumb 10 years ago because I didn't realize that there was such an effective possibility to treat CTPH with a balloon. You saw the lesion here. Let me go back and show you again. I think it's worthwhile. This is a very nice example of a subtotal occlusion here. The balloon is opening up just here. 3 months later, there is fantastic remodeling by flow that also contributes to this decline of pressures. And remember, it takes 3 months to get all this remodeling. My teacher, and who I really owe a lot of my knowledge on CTEPH from 2014 on, is Professor Matsubara, who is in the hospital center in Okayama. He illustrated very nicely, PA is a one-stop shop. BPA is not. You have to be persistent, you have to convince your patient to return, and you have to not create any other complications by bringing them back so often. This is the overview of efficacy of BPA prior to RACE and Mr. BPA. Those are the key 2 studies that I will show you in a moment, have been published in August in Lancet, head-to-head. This is evidence before, and if you look at the change of PVR was 43 something, and the change in mean pressure, 30%. So you do see there is a different mode of action compared with medical. Medical really is as it stands today, is a vasodilator treatment that effectively increases cardiac output, doesn't change the mean pressure substantially. So you do see there is a major difference between those 2 treatments. And of course, BPA carries complications. You should remember that there is some 10% pulmonary injury per session. It's always good to remember this is a per session. And death rate is in the 1% range, which is very nice. If you consider surgery, the best surgeons have a peri-procedural mortality of 2%. And this is the daily occurrence of well, I'm not saying daily, but you get hemoptysis quite often, and whoever does BPA has to know how to manage hemoptysis. So, medical or BPA was a burning question already in 2013, and there were 2 parallel studies initiated at this time. In Japan, the Mr. BPA trial, which I show you here, it was a multi-center trial of patients undergoing BPA or a Rio-Sigwart treatment. You see the up-titration. The primary endpoint was at 12 months. And while BPA could lower the mean pressure by 16, this is how it is reported, Rio did it 16 millimeter mercury. Rio did lower the mean pressure by 7 millimeter mercury. So the study was positive in the direction of BPA. And this is shown here for the mean pressure, for the vascular resistance, for the right atrial pressure, and cardiac output. And it's also illustrating the increasing cardiac output due to Rio versus the decrease of mean pressure due to BPA. And RACE was the head-to-head trial initiated in the French group by first authored by Xavier Jailly. This was a very pragmatic trial of patients evaluated in a team, operable versus non-operable, and it's a good illustration of how we should proceed. Then there was randomization if patients were eligible for BPA, which is the majority, of course, but some patients were ineligible. And then standard treatment with Rio was compared with standard treatment plus Rio was compared with standard treatment plus BPA. At 6 months was the first evaluation. Then there was an add-on for those remaining with a PVR above 4 Wood units, and so there was a swap for the Rio to BPA and for the BPA to Rio. And this was an interesting study reported here with a decrease to 41% of baseline value of the 26-week geometric mean of PVR, so speaks to BPA as the Mr. BPA study. And this is really very good evidence from 2 parallel studies in 2 very different ethnology groups and populations and hospital settings that BPA works very well compared with medical. But this is, of course, a scientific question. It's not so pragmatic because today we know we combine, of course. And that has been very nicely demonstrated in the crossover part of the RACE trial, where they looked at 12 months in the group that had primary BPA was then evaluated versus the primary Rio group, and you get a very big decrease in PVR in the 60 to 70% range. And if you look at the Japanese paper, the Mr. BPA study, this is also what they got. But the French could also demonstrate that if you combine Rio with BPA, you may be able to decrease your complication rates. And they had actually only 2.5% SAEs per session if you looked at pre-treated patients. So that's a good signal. It wasn't powered to show us that we need to pre-treat, but I think it's a very good stimulus. And then was Christoph Wiedenroth in Bad Nauheim, where I showed you the very nice picture of the hybrid room. He did a sequential BPA plus Rio Seguat study and can demonstrate in this open label design that there's an additional effect. We also have data on BPA plus treprostinil, and we do see a similar decrease of PVR. So there is a good collaboration between mechanical and medical. What about before? This was already discussed. There is no signal that it works before PEA. I'm running through this. This is from the CTEF registry. This is the old Jensen work. I'm very attached to the San Diego group, as you may know, and they didn't see any effect as much as the more recent manuscript that you showed. And then there was this unfortunate study that was called the bridging trial that was very nicely designed and never happened. And we could put a big virus behind this, the coronavirus, but in the end, we have no evidence. It was never completed. And I'd like to point out this study that will come up probably in a year and a half or 2 years. This is, again, as you see from the layout of the trial design, this is from the French Reference Center, and it will test the hypothesis that combination treatment prior to BPA will be a great strategy to improve the safety of BPA and to improve hemodynamics in the end. They will evaluate it 16 weeks. So basically, it's a group who is eligible, will be randomized to standard treatment with Rio and massive pre-treatment versus Rio alone. So I think it's interesting. It's the IMPACT trial. What about PEA or BPA? You may have asked this question. There's a small group of European SAPH centers who will randomize one-to-one a group of patients who are suitable for either procedure. So the question to the patients will be, do you want to have one surgery where you can die, or do you want to have several procedures in a row? You may have a complication, but and the results may not be as great. What do you prefer? So I think it's challenging, and I'm very much looking forward to the GO-SAPH trial. So what do we do currently? And I've looked into the literature, and I've confirmed that we are moving towards using all three components in the life cycle of a patient. The original question is, what is my initial treatment? Having in mind, if that doesn't work, I have a way out. And this is taken from the Kim Kerr's US SAPH registry, the pre-op medical treatment, or the treatment on any PH treatment, I'm sorry, the PH treatment after operation is in the 40s I'm sorry. What this shows is that the treatment pre-surgery, when they get referred, is in the 40s. And after surgery, this is not on the slide, it goes down to less than 20. For the BPA, this was published in 2017, patients have a 50% rate of pre-treatment, and that doesn't, at the time, really go down a lot. 40% remain on. I'm hearing from Professor Matsubara that they are stopping, as we do and other centers in Europe do. But in summary, medical treatment is an accompaniment of many patients undergoing BPA, particularly in the learning curve. And as we will learn from IMPACT, it may actually increase the safety of BPA. But I do believe if we do BPA well, we will be stopping treatments, more like continuing. And to answer these questions that I've raised and that you have raised, the team registry has been designed by the International CTPH Association. You see the effort of an international prospective multi-center registry that is about to start very soon, and that will be looking at the use of multimodality treatments in chronic thromboembolic pulmonary hypertension, and maybe gain some insights in who are the patients who should first get A, B, C, or D, according to what I showed you in my presentation. Well, thank you for your attention, and hopefully we can discuss.
Thank you very much, Professor Lang. Can you join us here, please? And now we'll open the floor for questions to the three speakers. Abdullah.
Fascinating three talks. Thank you so much. Especially the last picture of Fai's presentation was the best. Irene, since you have the balloon angioplasty as established treatment model in your center, have you noticed a change in your threshold for putting patient for operability versus, having them treated, especially after RACE trial? And did you have a change in this, your assessment for operability for SAPH patients?
Excellent. So thank you for this great question. There is a manuscript on this very important issue. It's been published by Elie Fadel, the French surgeon. And what they observed is what we also observed, that the patient referral has increased, at least by 1/3, taking into account Corona and all these other hurdles of medical systems in the past. But we have more referrals, and we have a much more tight multidisciplinary discussion. Because I see in the lab patients who I cannot help with big clot centrally, and they see patients more that they know now that there is an option for the distal, very hard to treat lesions. So it's actually very good evolution. We have learned how to do good angiograms, and surgeons are saying now, wow, I never saw this before. Why didn't you show me? And we respond, this is because we do BPA. We know better. So I think that the evolution as published by Elie Fadel is more cases, better MDT, and a much clearer separation of where BPA helps and where PEA is mandatory.
Second question, now when you have a patient with residual pulmonary hypertension after surgery, after pulmonary endarterectomy, but the patients normally they do very well, especially if the range of their mean pulmonary artery is in the 20s, upper 20s, maybe lower 30s. We discuss this all the time in our daily practice. Now, if the patient is completely asymptomatic, like functional class 1, normal, pro-BNP, good 6-minute walk test, what's your threshold of starting these patients on medical therapy, or even thinking of PBA? What's your mean pulmonary artery pressure threshold? What's your range? Or just leaving them alone because they are doing very well?
Another great question. My attitude is to follow up on every patient after PEA with a pulmonary angiogram. If there are lesions that are easy to treat, I do them, regardless of the symptoms. Because I do know that it gets worse over the years, and when the patient presents, we can prevent escalations of pressures. This is my attitude. I don't think there is a rule, and I think you may say, why do an intervention if this is potentially harmful? But I think PPA has become very, I'm not saying harmless, but it's very calculable risk. And if I find residual lesions that are significant, mainly proximal, that I can treat well, I do it immediately.
Last question to Faiz. You showed very nicely this small vessel disease with pathophysiological, histopathological, pathobiological changes, inflammatory cells, and all of these things. So did you notice a difference between those patients who have active hematological/rheumatological illness leading them to CTEPH? Do they behave differently in terms of the outcome after surgery or medical treatment and other things?
Yeah, very important question. Yes, we do, as we see in daily practice, patients with underlying antiphospholipid syndrome, they have very large clot burden, recurrent PEs, VTEs, and even after the endarterectomy, they do, I would say, a bit complicated course as compared with the other patients without risk factors. So they have high hemodynamic numbers even after the endarterectomy. Sometimes they have a recurrent VTEs. So yeah, I do believe they do a bit worse in comparison to the other regular CTEPH patients. Actually, yeah.
You have a question? Yes. Go ahead.
Dr. Mohammed from Kingdom of Bahrain. Thanks for the speaker for this nice illustration for CTEPH and CTED disease. I have a question regarding those patients who are having a recurrent CTEPH, those who are already undergone PEA. Do you advise to repeat the PEA, or you will go just directly for BPA or medical treatment?
That's a question to Professor
Yeah.
Yeah.
Well, thank you for this question. The question, first aspect, is it recurrent or is it persistent? So that we have been discussing a lot about this. You wanted to respond to this?
Yeah, it's a recurrent.
So was normal, documented, and later comes back with?
Yes.
So the first question is, was anticoagulation sufficient? We have seen, I mean, in Vienna and in maybe bigger centers, re-PEAs, but very rare for patients who clot again if they don't take their medications. We've had 2 cases in Vienna. I think every center has 1 or 2 cases, depending on the size of the center. Usually we reassess. We do pulmonary angiography. You see, I'm driven by the lesion morphology. And then we discuss in the team, how do we proceed? And usually, this is a case for BPA, because another major surgery may not be your first choice. It's almost like if you have an aortic valve that's dysfunctional in an 80-year-old, you go for the less invasive or TAVR. And very similar in the CTEF. If you have had a surgical patient and they get, you document, again, high pulmonary pressures, you look for the lesions. Is there any lesions? Usually it's not recurrent, but it's persistent. It's persistent, overlooked. And then you have to find the lesions, which is very hard. There's data from Papworth, and I think from Italy, from Massimiliano Palazzini, that BPA after PA is very difficult. I think they are right, if this is several years before. I have had actually very good success after pulmonary endarterectomy to do BPA. But occlusions are very hard, so it's a different style after PA.
Yes, Professor from Fairfax. I'm bad with names. Introduce yourself, please.
Hi, Oksana Shlobin from the United States. So Irene, just to follow up, how's the approach different when you do BPA after PT? So that's the first question. And the second question is, we have a small CTEF center, but we have observed some patients who have BPA who are older, who do come in with diastolic dysfunction, or in whom diastolic dysfunction becomes more apparent after BPA. Can you talk a little bit more about how you approach those patients, maybe medically, before you do a procedure, or in the interim, if you sort of uncover this diastolic heart failure, which becomes more apparent clinically?
Two very good questions. So number one, if you do BPA after PEA, be prepared. You have to first identify the lesions, which is more difficult because there has been somebody going through all the segments. So watch out for chronic total occlusions. They're very hard to see also sometimes for surgeons, although they have the direct view. Remember that, as I mentioned before, that lesions are very hard. You may have to upscale your wire technique. You may have to select procedures just to do one segment. Don't be disappointed to focus on one segment for 30 minutes because it's very hard. I think if you are able then to open, you get a great success, because those are the lesions that they need, and we usually lose in the lower lobe of the right lung. This is, if A10 remains occluded, which happens sometimes, there's no way that they ever get normal. So you have to focus on this. So this was response to question number one. Response to question number two is the diastolic dysfunction. So we have seen that patients with diastolic dysfunction are more often in AFib. So the biomarker rule is lost. You cannot go by the BNP level to judge any of your successes. So you lose a marker. Some have renal disturbances, so we have to pay attention to this. Short procedures. The third is you may want to optimize SGLT2 inhibitors today and make sure that the heart failure treatment is as its best. This is our approach.
Thank you.
Just a comment about BPA post-pulmonary endarterectomy. One of the main reasons that makes it a little bit difficult in terms of technical wise, the disease that's still there, that was not first fixed surgically, it's way distal. So the more distal that you have disease, the more difficult technically when you do BPA. The more proximal disease you have, the more easier that when we intervene doing BPA, it's much easier. I think this is one of the main reasons. It's very distal disease. Go ahead.
both of you, Dr. Lak and Dr. Ahmadi. So I understand the balloon angioplasty is done over weeks and months, multiple sessions. And you've shown nicely the PVR and mean pressure dropped by almost 30%. So for how long is this response sustained? What is the longest patient studied? When do you have to repeat the balloon angioplasty? Is this sustained for years, or you have to keep doing this with the attendant risk and 1% mortality?
That's a great question also. The answer is coming from the Japanese. I'm sorry that I start talking. So they have 10-year data now, and there is no signs of recurrence, if you're alluding to this. I showed you the webs. So when you dilate, you're not hurting the media, so you don't get restenosis. And you get, there's some patients with incomplete BPA who may come back with pulmonary hypertension. So please go below 30 mean.
So I reviewed the paper, as Prof. Iron said, about it's in the Japanese registry. So they pulled all the data from different centers in Japan, and they saw it showed actually sustained response for at least 3 years with almost normal pulmonary artery pressures. Yeah. Yeah, I have a question for Prof. Iron. So it's really simple question. So in patients with the CTEPH without antiphospholipid syndrome, what's your preferred anticoagulation? NOAC or vitamin K antagonist?
Yeah, that's a good question. Did you show Mark's data on the expert registry? I think you showed that.
Yeah.
So they showed that there was no advantage in terms of complications, but there was a little advantage of vitamin K antagonists. And I think I use vitamin K antagonists because I understand that CTPH is complicated thrombosis, and that is not driven by a single coagulation factor, but you have all the inflammatory mediators that trigger thrombosis, and the broadest we have is still the vitamin K, while the NOACs are pinpointing to 10A or 2A, right?
Yeah. So regardless, you use it in all patients? I use vitamin K
antagonists, and for phospholipid patients, you have to anyways.
Yeah. What's your approach?
My thanks all, and Sudair Pharma, sorry. I know I will forget one of them. And TMT, thank you, Hassan. And my thanks always goes to Hassan Al-Araini, because without his high-level organization skills and communications, this conference would not have been a reality. So thank you so much, Hassan. Also to the audiovisual company, thank you for your great support. We have not decided yet where to do and where to hold our next SAPH 2024, but the board will be meeting soon, inshallah, and we'll decide and we'll let you know. One final note for my younger colleagues, as you could see clearly that this is a very complex disease. The treatment before that, the diagnosis need to have a comprehensive protocol approach, and the treatment obviously needs highly sophisticated centers where they have an experience for pH management. So for the time being, until you become an expert, please try to get patients referred to the big pH centers. Country like Saudi Arabia, alhamdulillah, have multiple pH centers, especially in Riyadh and main cities, Jeddah and Dammam. The referral system is very easy. You have a hala, you have also contact with your colleagues who have been leading these pH centers in the country. So no reason not to refer sick patients to these big centers, and obviously giving them the chance to have the best treatment. I think final note, we will be serving dinner in the same hall last night, the night before and day before. And then I hope, for every one of you, a best journey back home, and we'll see you in SAPH 2024. Thank you so much.
You mean lunch, Abdullah, because dinner will keep us the whole day, huh?
it's a custom for staff to have a group photo. So if we can, be here in rows, so we can take a photo for everyone, please. The speakers and the chairs, please come here on the stage. And, the rest try to accommodate, please.